rare, as is been mentioned conventionally. So I wanted to emphasize that we should not miss these cases, because the first 3 cases were not typical explanation of what we get in the books. So like if you see a retrolental flare and like headache, history of headache is there, then we are very much there, because we see, very often we see cases of leakage in our OPDs, so we need not miss that. And then if we get a case of uveitis, we give a battery of investigations, which everything is not required at the first instance. You treat with IBMP, and then for a few immunosuppressants also for a few months has to be given in these cases, and the prognosis is like it's very gratifying. It's gratifying for the patient as well as for the doctor who treated. So please don't miss a case of leakage, and it has to be differentially diagnosed like the CSR, central serous retinopathy, because the OCT picture, those are same. And the treatment is, if you give a steroid, you should not give steroid in CSR. That is very important. But if you don't give a steroid in leakage, you'll never get treated. So this 2 differential diagnosis has to be done in the OPD. And this is the OCT picture, the last one, the first OCT, which is which was described in 2009 in American Academy of Ophthalmology. So if you go through this article, I think you will never miss a case of leakage in OCT. Thank you so much.
Thank you, Dr. Gitumani Sharma. There are different types of uveitis cases you have presented. So, any interaction, please?
Nice presentation.
Thank you. Thank you, judges.
And leakage is rare, I think. So, it is a good presentation.
So after this, we will be having Dr. Gorima Rani, who will be talking on ocular surface squamous neoplasia. Dr. Gorima Rani, please.
Good morning, one and all. I'll be presenting my case report on ocular surface squamous neoplasia. It consists of pre-malignant and malignant changes of corneal and conjunctival epithelium, includes moderate to severe dysplasia, carcinoma squamous cell carcinoma in situ, invasive squamous cell carcinoma. Risk factors include UVB exposure, chronic trauma, vitamin A deficiency, exposure to arsenic, beryllium, HPV and HIV. They have strong association. It usually presents as unilateral vascularized mass. Morphology ranges from gelatinous, leukoplakic, papillary nodular, and nodular ulcerative. So a 35-year-old female presented to us with soft pinkish white mass in the left eye since 3 years, which was insidious in onset and was progressive in nature. There was no associated pain, watering, discharge, or any history of ocular trauma. She was diabetic and on insulin for last 13 years. Uncorrected visual acuity in the right eye was 6.6 and the left eye was 6.24. On ocular examination proper, there was 10 mm into 6 mm mass on the conjunctiva and the cornea, which was pinkish white mass elevated with irregular borders, soft, non-tender, encapsulated with gelatinous surface. It was freely movable with 3 feeder vessels to the mass. There was no active bleed from the mass and no palpable lymph nodes were seen. Fundus examination showed mild NPDR both sides. Routine blood investigation, viral markers and pre-operative B scans were normal. So patient was planned for excision, frozen section biopsy followed by cryotherapy. So no touch technique was used. Mass was excised with 4 mm. Mass was excised with 4 mm uninvolved margin. Keratoepitheliectomy was done. Cryotherapy was done with double rapid freeze thaw technique, and then mass was sent for frozen section biopsy, which showed positive margins for nasal and which shows a positive margin containing dysplastic cell, nasal and temporal margin. So again 1 mm excision was done and cryotherapy was again repeated. Then mass was sent for histopathological examination, which shows moderately differentiated squamous cell carcinoma. So patient was started on 0.02% mitomycin C drops, 1 drop 6 times, 1 drop 4 times left eye for 1 week, followed by rest for 1 week, to be repeated for the next 6 cycles, but she developed allergic reaction, so mitomycin C was discontinued. She was further planned for amniotic membrane transplantation with 1% 5-fluorouracil, but amniotic membrane was not present at that time, so she was shifted to antibiotic steroid drops for 6 weeks in tapering dose. After 6 weeks, frozen section biopsy was again repeated, which shows negative margins confirming no recurrence. So patient is still on follow-up. So this case is important because usually OSSN, it mimics numerous ocular surface pathologies like conjunctival cyst, malignant melanoma, pinnacular pterygium, so a high index of clinical suspicion should be there to pick it up early. Thank you.
Thank you, Dr. Gorima.
Thank you, sir.
Yes, very nice presentation. Very often you come across this type of lesions, ocular surface squamous neoplasia. So, what is the other diagnosis you thought, differential diagnosis for this?
So the clinical presentation was more towards
OSA. So, whether you have to do the FNSC, etc., to confirm your diagnosis before surgery? Role of FNSC is there in these cases?
role of FNSC. So actually we did frozen section biopsy.
Frozen section biopsy have taken?
Yes, sir.
Or before complete excision?
So complete excision was done.
Then you have done biopsy. That is frozen section biopsy. Oh yes, frozen section biopsy you have done.
Yes,
then
sir.
confirm, then you have gone for...
Then on frozen section biopsy, the margins were still positive for the dysplastic cells. So we again excised the margins, and then it was sent for the histopathological evaluation.
So it is minimum manipulation is required. So
Yes,
you excise, how many millimeter free margin you have
So
taken?
4 mm free margin was
4 mm
yes,
free margin, and the margin is freezed by cryosurgery.
Yes, sir. Yes, sir.
Cryosurgery you have done.
Yes.
So and then you have not given the amniotic membrane.
So amniotic membrane, sir, we decided that we'll give, but at that time it was not available. So we started the patient with mitomycin C drops, sir.
Mitomycin.
Sir, but patient developed allergic reaction. She was having irritation, and then we stopped that, and then we started dexamethasone, sir, antibiotic steroid drops.
Yes. So what is the course of mitomycin C for
Sir,
how many days?
So we, in this case, sir, we gave it for 1 week.
1 week. Yes.
1 week we gave, one drop 4 times,
Yes.
1 week we gave, and then 1 week rest. But by that time, before 1 week only, she developed severe reaction.
Reaction
Yes,
to
yes, sir, mitomycin C, yes, sir.
Yeah.
So we stopped eventually, yes, sir.
So when we treat the mitomycin C patient must be hospitalized.
Yes, sir.
So you have to follow up daily.
Yes, sir, yes,
Is
sir.
there any reaction of course?
Yes, sir, yes, sir.
Then you have converted to steroid.
Yes, sir.
Steroid.
Yes, sir.
Now patient is follow up.
Yes, sir.
How many years? How many months follow up?
So patient is regularly following up every 1 month. Before it was for 2 weeks,
Yeah.
2 weeks and then 4 weeks, and now she is like coming every 1 month, sir.
Every month.
Yes, sir. Last time when she came, we did again frozen section of the conjunctival margin, sir. So it was negative only.
It is negative.
Yes, sir. Yes, sir.
Okay, very good.
Thank you,
Very nice
sir.
presentation.
Thank you, sir.
Excuse me, Dr. Garima. Actually, I want to just add one.
Yes, sir.
So you can have a conservative management also in this case, or any other OSSN with interferon, topical
sir.
interferon.
Yes, sir.
And angiosegment OCT also is having good role
Yes,
to
sir.
play
Yes, sir.
for diagnosis.
Yes, sir.
Thank you.
Thank you, sir.
Other than the OCT also has got role.
Yes, sir. Thank you, sir.
So next we'll be having Dr. Tanveer Ahmed. He'll be talking on retinitis pigmentosa in a suspected case of Lawrence-Moon-Biddle-Bardet syndrome. Dr. Tanveer, please.
Very good morning to the respected panelists and to the house. This is Dr. Tanveer Ahmed from SMCH. Today I'm going to present a case on retinitis pigmentosa in a suspected case of LMBB syndrome. So a 15-year-old boy presented to the opthal OPD with his mother with the chief complaint of dimness of vision since his childhood. As per his mother, the complaint of dimness of vision was more during the evening hours and in environment with dim light, and it was gradually progressive. The mother also complained that her son is not mentally sharp and he has extra fingers and toes. His sister also suffers from retinitis pigmentosa, diagnosed outside in a tertiary center. So while examining the patient, we have found that the patient was obese with a somewhat protruding belly. Hexadactyly of the post-axial variety was seen in all the 4 limbs. That is, there were total 24 digits. The IQ seems to be on the lesser side. He was referred to psychiatry department for mental status evaluation, and they evaluated him as borderline. There was a small penis with an undescended testis on the left side is seen. In the ocular examination, the vision was markedly reduced in both the eyes with hand movement perception, and in the slit lamp examination there was mild PSCC noted on the both sides. In the fundus examination, there was retinal epithelial pigment changes with mild attenuation of vessels with pale optic disc. Few bony spicules at periphery were noted. This is the fundus picture. MRI was advised but could not be done because of financial issues. The CT brain ruled out ICSOL. USG scrotum revealed there is a left-sided undescended testis, and ECG shows sinus tachycardia with no other defects. In the management part, we have given the best corrective visual acuity, though it was not very much promising in this case. Parents were counseled regarding the outcome and also about the genetic involvement of the diseases. A disability certificate was provided to the patient, and life doesn't end when there is when we don't see an end. And patient was sent to a local NGO Saksham, where he is learning music and a few more skills nowadays. Thank you.
Thank you, Dr. Tanvir. Any interest?
Yes, very nice presentation. One question is that whether retinitis pigmentosa is common in Lawrence-Moon syndrome?
Sir, the LMBB syndrome has got two components. Earlier there was Lawrence-Moon syndrome is one thing, and Bardet-Biedl syndrome is the another one. Now the combined picture is LMBB syndrome. In the LMS, the retinitis pigmentosa is a component. And in the Bardet-Biedl syndrome, the polydactyly and the obesity is the component. And now we see, to describe it as an LMBB syndrome, we have 6 primary criteria, out of which 4 must be positive, and we have around 10 secondary criteria. If we have 3 primary characteristics and 2 of the secondary features, then also clinically we can call it as an LMBB syndrome. So retinitis pigmentosa is an integral part of this LMBB syndrome, sir. Thank you, sir.
Thank you, Dr. Tanvir. Now we will be having Dr. Debojit Deka. He will be talking a case of unilateral proptosis. Dr. Deka, please.
Good morning, everyone. Today I will be presenting a case of recurrent unilateral proptosis. My patient is a female patient, 52 years from Hailakandi, presented in the IOPD with chief complaint of swelling of the right eye for last 7 days, which was sudden in onset and progressive in nature. And the symptoms were associated with redness and mild pain and forward protrusion of the right eye for last 7 days. She had 2 similar episodes, 36 days back and 1 year back, which was treated with steroid and was well controlled for last 1 year. And she had minor trauma in the right eye for 5 years back, which was found to be insignificant in this disease procedure. She is a known case of hypertensive for last 5 years, well controlled on tablet telmisartan and amlodipine, and no other significant relevant history. On clinical examination, systemic examination, it was found to be within normal limit, and in ocular examination, the right eye showed the visual acuity of finger count at 1 feet, and lid was edematous, conjunctiva was congested and chemosed. Pupil was mid dilated and sluggish to react. In fundoscopy, cells were dilated and torsus, and this was found to be normal. FR was dull. In the left eye, the visual acuity was 6/12. The other findings were within normal limit. Examining the proptosis, it was unilateral, confined to the right eye. It was axial, and Nebzager sign was positive. On 2-scale proptometry, right eye found to be, right eye measured 19 mm, and the left eye it is measured 11 mm. All relevant investigations were done. The blood parameters were found to be normal. Thyroid profile was normal. Anti-nuclear antibody was found to be negative. And in the MRI, it showed all extraocular muscles were bulky, with enhancement on post-contrast study. And the right optic nerve was also found to be bulky with enhancement on post-contrast study. And the features were suggestive of orbital pseudotumor right eye. After excluding all other causes of the proptosis, a diagnosis of orbital pseudotumor right eye was done, and parenteral steroid was started. But with injection dexamethasone, the improvement was not satisfactory. So injection methylprednisolone, 1 gram with 100 ml NS, OD was given for 3 days, and it showed that the dramatic clinical recovery, and it was maintained well with oral prednisolone, and the patient was discharged as such. The idea behind presenting this case is that what should be the next? If patient had already 3 episodes, so if patient comes with another episode, we have the following 3 points, I think. So whether to continue low dose steroid for long duration, but patient is a hypertensive case. We can re-evaluate again, but it's a exhaustive procedure. Or we can do a few further investigation like muscle biopsy, monoclonal B-cell antibody, or antimetabolite. Thank you.
Thank you, Dr. Deka. Any interaction?
How you differentiate with euthyroid ophthalmopathy?
Sir,
Euthyroid ophthalmopathy, how you differentiate with this case?
there is no any systemic signs of thyroid
But
disease.
that is euthyroid,
Yes, sir.
euthyroid ophthalmopathy. Can you show me the picture of CT finding, CT or MRI? So, how we differentiate pseudotumor, idiopathic inflammatory disease, with thyroid radiologically?
Sir, radiologically, there will be
I will better say it as a case of euthyroid ophthalmopathy. Then I will justify your case.
yes, sir. In the thyroid case,
In thyroid cases,
sir.
there is muscle involvement.
Muscle involvement.
But here, I think the muscle is bulky.
Yes, sir.
Can you show me the picture, please?
No, he cannot say. From center.
Want to slide ako slide yes. Slide kon slide. Okay. So the muscle is bulky, I think.
Yes, sir.
So I think it is a euthyroid ophthalmopathy.
But in the report,
Muscle is
report,
involved.
report, it was given that tendons are also involved in these cases. So in
But muscle is definitely bulky.
sir. In thyroid cases, the
In
tendon are
unilateral
spared.
proptosis, the
actually.
most common cause is thyroid ophthalmopathy. There are 3 types. The
Sir,
euthyroid
in
is
the
very-
report, it was given that the tendons are also involved.
Any expert opinion, sir?
Yes, because tendons are also involved, so it may be case of the pseudotumor. Because in case of thyroid ophthalmopathy, only the muscle belly is involved.
Belly is involved, sir.
Muscle belly is.
Thyroid parameter done, sir. Yes, sir. Or normal level. And
But-
there was no any external finding. So discharge, there was no any discharge. In thyroid ophthalmopathy, there should be some discharge actually. Sorry, sir. Yes, sir. The last 2 episodes, in that there also it was resolved with steroid. But that time it was treated with dexamethasone, and this time dexamethasone there was no any satisfactory improvement. So methylprednisolone was given. Yes, sir.
So I just want to have a comment because it's a presentation. So we must have a proper exophthalmometer to actually demonstrate what is the proptosis.
So
But-
actually we did the Lewis principle.
You should have this access to that exophthalmometer for presentation of a proptosis case.
Yes, sir.
Thank you. Thank you.
Thank you, sir.
So next, we will be having Dr. Sani Rajak. He will be talking on blood-stained hypopyon in anterior chamber, a relapse in acute lymphocytic lymphoma. Dr. Sani, please.
A warm good afternoon to everyone present here. I am Dr. Sani, second year postgraduate trainee. I am going to present a case on blood-stained hypopyon, a relapse in acute lymphoblastic leukemia. This is my patient. This patient was admitted in the Department of Pediatrics from the past 15 months. Currently, the patient already completed the 10 cycles of maintenance therapy. His maintenance 10th cycle was completed on 6th April. After which the patient presented with diminution of vision associated with photophobia. This patient was referred from the Department of Pediatrics to our department. On examination, as you can see on right eye, there was a blood-stained hypopyon was there, which was around 2 millimeter in height. In bilateral eyes, the palpebral pressures were decreased with mild congestion on both eyes. On right eye, the pupil, it was irregular, fixed, not reactive to light, whereas on left side, it was within normal limit. Anterior chamber of right eye, it was shallow. Hyphema was positive. Hypopyon 2 millimeter AC cells were seen. Right eye iris segmental forward bowing on the supratemporal and infratemporal regions were seen. On lens, there was pigments over the anterior capsules, on the anterior capsule of the lens. On intraocular pressure was 43.4 millimeter mercury, whereas on left eye, on anterior chamber, it was again shallow with AC cells 2 positive. There was only forward bowing of the iris. On lens, again, there were some pigments. On intraocular pressure was 20.6 millimeter mercury. On fundoscopy on right eye, it was fundoscopy. It was blurred because of the presence of vitritis. On left eye, it was within normal limit. On peripheral blood smear, it was seen that microcytic hypochromic RBC were seen, which were admixed with normocytic normochromic RBC with few atypical lymphoblast cells. MRI brain with orbit, there were few microbleeds in bitemporal parietal and left temporal and left occipital lobes. T2 hyperintense mucosal thickening is noted in bilateral maxillary sinus suggestive of maxillary sinusitis. A diagnosis was made of unilateral blood-stained pseudo-hypopion uveitis with secondary glaucoma, which was masquerading as a relapse of acute lymphoblastic leukemia. A conservative management was done on the line of uveitis, and as peripheral blood smear already shown atypical lymphoblast cells, so the antechamber tapping was withdrawn, and the patient was again referred to the Department of Pediatric Oncology for evaluation of relapse of ALL. Thank you.
Thank you, Dr. Sani. So, any interaction, please?
What are the other causes of blood stain hypopion? Depends on
Ma'am, trauma.
any other?
Ma'am, anterior uveitis. Anterior uveitis can also cause blood-stained hypopion.
So in the other eye, is there any findings? Other eye?
Other eye, sir,
Because it is leukemia, it is maybe bilateral involvement also.
sir, on fundoscopy it was normal. Anterior segment were normal. Only during slit-lamp examination, there were few cells, and anterior chamber was shallow, sir.
Other eye?
Yes, sir. Anterior chamber was shallow.
But no, there is no hemorrhage, etc.
No, sir. Hemorrhage was there only on right eye.
Only on the right eye.
It was a unilateral one.
Okay, thank you.
Stage, or you have tapped the AC tap and then it has come.
No, sir. Actually, on peripheral blood smear already there was shown that there is the presence of atypical lymphoblast cells. Before we were going for AC tap, but as the peripheral blood smear already shown that there is a cells, so we just referred the patient to pediatric department.
But there is a glaucoma, you see, hypema, glaucoma. Yes. You should add at least one anti-glaucoma drug.
Yes.
It's too high.
Yes.
Dr. Sani, what do you think this is because this hypopion, blood stain hypopion is due to what? It must be because of the uveitis. Is not it? Is it actually due to ALL?
Yes, sir. Actually, sir, as you can see, blood stain hypopion is there, but the congestion it doesn't. It is like disproportionate with the presence of hypopion.
Uveitis was there or not? That is the thing actually.
Yes, sir. Uveitis was there. Yes. Sir, peripheral blood smear showed that there is a lymphoblast cell. Yes, sir.
Actually, with your apology to my mentors, actually this case was apart from the pediatric oncology department, and we have seen some typical, we have followed up 10 or 15 cases, we have found some atypical presentation, like can you move the later slide? And the bowing of the iris pattern, we have found in many cases. And though we are thinking to do AC tap, but already it is an established case, and when you treat at the line of uveitis, the case, the picture are going to be perfect, and on the follow-up, IOP also it's become normal. So the picture will be clear later on, actually, whether it is a relapse, whether it is a secondary glaucoma due to that hypema, or any other cause, relevant cause. But as Pankaj rightly said, the glaucoma management is utmost important.
Just to add here, so there is actually literature it is said that herpes simplex uveitis, iritis, may be there in case of ALL. So that may be the cause of uveitis there, which is not typical to other uveitis.
Okay,
And so that may be cause of this hypopion.
okay, sir.
Thank you.
Thank you, sir.
So after Dr. Sani, so we'll be having Dr. Jessica Bosomatri. She'll be presenting Tinu syndrome, unusual case of childhood uveitis. Dr. Jessica, please.
A very warm good morning to one and all present here. Today I'll be presenting an unusual case of childhood uveitis, Tinu syndrome. So a 16-year-old male patient presented to our OPD with chief complaints of intermittent redness, photophobia and pain in both his eyes for the last 4 months. Patient had consulted elsewhere and was using prednisolone eye drops in both of his eyes. The history was negative for any kind of trauma, joint pain, cough, any ulcer in the body, or any history of oral intake. However, the patient did complain of abdominal pain, which was our first clue. Coming to the examination, the vision in the right and left eye was 6/9. IOP in the right eye was 13 and in the left eye it was 14 mmHg. And this is a slit lamp picture. The redness had resolved because the patient was already on prednisolone, but on examination, we found the presence of fine KPs on the corneal endothelium, and there was AC reaction. The findings of the left eye was similar to the findings of the right eye. So then this is a picture of the fundus. We can see that the media is clear, disc, vessels, macula all appear normal. The HROCT is normal, foveal contour is intact, so there was no evidence of intermediate or posterior uveitis. Hence, based on our clinical findings, we came to the diagnosis of bilateral anterior uveitis. But since the patient complained of abdominal pain, we conducted an abdominal palpation and found that there was flank tenderness more on the right side. This was our second clue. So a basic uveitis workup was sent along with urine analysis for beta-2 microglobulin, which is a very sensitive marker for Tinu. So what we found was, interestingly, the beta-2 microglobulin level was significantly raised, along with the presence of trace blood and RBCs in the routine urine picture, as well as raised creatinine levels. So based on these laboratory findings, we revised our diagnosis to bilateral, probable case of tubulointerstitial nephritis and uveitis syndrome, based on the Mandeville criteria. The patient was advised to add homite along with the prednisolone eye drops that he was already using, and a nephrologist opinion was sought. The patient reviewed after 2 weeks. The eye was stable and the AC reaction had died down, and the patient was on prednisolone oral 1 milligram per kg body weight as advised by the nephrologist. The patient was then followed up after 2 months, and it was seen that the beta-2 microglobulin levels in the urine had reduced. So I would just like to conclude by saying that the prevalence of Tinu is 0.1 to 2% globally, and this could be because it is underdiagnosed and underreported. So much so that, in fact, in a clinic in Northern Ireland, all children who present with acute onset bilateral anterior uveitis undergo urine analysis for beta-2 microglobulin. And it is believed that some of the cases of undiagnosed and undifferentiated uveitis can be because of Tinu. It is very important to come to a diagnosis, because if not, it can result in recurrent relapsing uveitis requiring immunomodulator therapy. So a proper history taking and systemic evaluation, like in our case abdominal palpation, helped us in clinching the diagnosis. Thank you so much.
Thank you, Dr. Jessica. It again re-emphasizes that the importance of the complete workup of any case of uveitis.
Yes.
Thank you.
Yes, this is bilateral uveitis or uveitis in children.
Yes,
We
sir.
must see the kidney findings.
Yes, sir.
That is urine examinations.
Is
other
important.
parameters we must have in our mind
Yes,
to
sir.
control this type of diseases.
Thank you so much.
So after Dr. Jessica, we'll be having Dr. Rima Kochari. She'll be presenting alveolar type orbital rhabdomyosarcoma, a case report. Dr. Rima, please.
Good morning to everyone present here, respected panelists, delegates. Today, I am going to present a case on alveolar type orbital rhabdomyosarcoma, a case report. It is the most common soft tissue sarcoma and most common primary orbital malignancy of childhood, which is a rare condition, and 40% develops in the head and neck. It arises from the pluripotent mesenchymal cells, which have the potential to differentiate into striated muscles. My case is a 7-year-old male child who presented with a swelling in the right upper eyelid for 6 months, which was painless, rapidly progressive, and increasing in size, leading to sudden onset proptosis of the right eye. On ocular examination, the right eye vision was 6/18, extraocular movements was full, free, and painless. However, there was hyperemic palpable conjunctiva of the right upper eyelid. Rest and three segments were within normal limit. On examination, the left eye was completely normal. The swelling was located in the superior nasal quadrant of the right orbit, which was firm in consistency and measured 3.5 cm into 2.5 cm. It was non-tender, immobile, non-pulsatile, non-expansile on coughing, and was of normal temperature. No bleed was heard on auscultation, and no translumination was seen. All the blood investigations were normal. Chest X-ray and EVG abdomen revealed no abnormality. However, the MRI showed preseptal orbital hemangioma, which was contradictory with our clinical findings. So we did a projection section biopsy, which suggested vascular relation with dysplasia of the overlying epithelium. So again, we sent histopathological examination, which the report showed lobulated tumor mass comprising of sheets of small round blue cells, which are separated by fibrous stroma. It has scant cytoplasm, hyperchromatic round to oval nuclei with inconspicuous nuclei. Mitotic figures were noted. They gave the impression of small round blue cell tumor. It could be either rhabdomyosarcoma or extraskeletal Ewing sarcoma. Immunohistochemistry was advised, and it showed positive vimentin, desmin, and myogenin, which favored alveolar type of rhabdomyosarcoma. So the patient was referred to Dr. B. Bora State Cancer Institute for further management. The discussion, though most of often the tumors arise de novo, a history of trauma may be associated with a clinical presentation. An increased risk has been noted in children with rare inherited diseases like Leigh-Fraumeni syndrome, neurofibromatosis type 2, and MAN2A. So in conclusion, it is the most common primary malignant orbital neoplasm in children, so it is suspected in a child presenting with rapidly progressive inlethal proptosis, and it is a good prognosis because of favorable anatomic location and histology and multimodal therapy. Hence, early diagnosis is very, very crucial. Thank you so much.
Thank you, Rina Kosari. So, any interaction, please?
Yes, very nice presentation. What are the other histopathological types of rhabdomyosarcoma? And which one is common?
Embryonal type, then alveolar, and pleomorphic type. Common is embryonal.
Common is embryonal type. Your alveolar is, what is the percentage of alveolar type? I think it is also next to the first type, that is, but what are the other rare type? Alveolar is rare, but more rare types are there. Okay, but fine. Thank you.
Thank you.
So next we are having Dr. Isa Agarwala. She will be talking botulinum toxin injection in the palpebral lobe of lacrimal gland for the management of epiphora. Dr. Isa, please.
I have no financial disclosures or any conflicts of interest. So at the end of this talk, we'll be basically having a solution, a quick solution to all the patients who come with epiphora, and we don't generally have any solution to what to do with that epiphora, and patient has constant complaints of watering. So epiphora, owing to the lacrimal outflow obstruction, affects a wide range of patients. It adversely affects their quality of life by causing blurred vision, irritation of eye, and periocular tissue and social embarrassment. Its standard treatment in the form of DCR depends upon the location and extent of obstruction. Surgery may not be the best option in all patients, especially in number one, elderly patients and patients having malignant lesions. So what does botulinum toxin exactly do? We all know the function of botulinum toxin is to relax or to inhibit. So injection of botulinum toxin in the lacrimal gland blocks the presynaptic release of acetylcholine, which is required for the tear secretion. So looking at this picture, we can see here is the lacrimal gland, which is present here. And this is basically the lacrimal outflow passage. We will do a good syringing, all the epiphora test that is needed. If we find a NLDO obstruction, we have no option other than a good DCR. But if a patient has, say, common canalicular obstruction, the patient does not generally resolve with a DCR. So in cases of common canalicular obstruction, and also in cases where plethora of nerve supply is involved, like the facial nerve, like the different divisions of the facial nerve, we can go for a botulinum toxin injection. So in this case series, we present a series of 25 adults where 2.5 to 5 units of botulinum toxin was injected subconjunctivally in the palpebral lobe of the lacrimal gland. So most of our cases in our portfolio included common canalicular obstruction, idiopathic hypersecretion, and facial palsy epiphora. So the method of injection was, we put the speculum, took a Dimas retractor, retracted the eyelid, we got a good exposure of the lacrimal gland, and we injected 2.5 to 5 units of Botox in the palpebral lobe of the lacrimal gland. So out of the 25 patients, in 21 patients, that is 86%, showed significant improvement with decreased symptoms of epiphora. Patients remained symptom-free for 4 to 6 months. 4 patients experienced transient diplopia. 1 patient had ptosis that lasted for a week, and 1 patient had subconjunctival hemorrhage. So I would like to conclude by saying that use of Botox is a simple injection technique that can resolve the epiphora and give the patients a better quality of life. The disadvantages is injection has its cost and it's a recurring cost. Relief is only temporary and it's not a permanent cure. Thank you.
Thank you, Dr. Issa. And the interaction.
Dr. Issa, it's a very good presentation. Have you obtained the ethical clearance as it is an interventional study?
Yes.
And what is the type of the study?
So the type of the study is
whether it is a prospective, whether it is a cross-sectional?
So it's a prospective study.
Now what is the p-value?
So the p-value is less than 0.0.
Okay. So I think it's a good study, but if you want to refine and if you want to modulate the study to a greater extent, so you have to clear about the study design.
Yes.
Whether it is a cross-sectional study, whether it is a interventional study, or is it a randomized control study, RCT.
Yes,
so
sir.
RCT is best suited in this case, and you should find a p-value.
Okay, sir.
This is my observation on this study.
Yes.
Thank you.
How many cases you have studied?
So we took 25 patients.
25 patients?
Yes, sir.
All are successful?
So epiphora symptoms were reduced, but in 4 patients we did get complications.
Complications?
Yes, sir. Transient diplopia. 1 patient had ptosis, but these were all transient symptoms which resolved itself.
How long you have followed up till now?
We started this study in 2021 end, and the patients have been coming to us like 6 monthly injection we generally advise to the patient.
All patients 6 monthly injection you are giving?
6 monthly patient, yes.
Yeah,
Sir.
How many injection you have given in one patient?
So one.
For the maximum injection you have given in your cases?
Ma'am, 2, 3.
2, 3.
Yes. And ma'am, some patients also had good results with even 1 injection, and the watering was significantly reduced. So they have not come for second injection. Some patients come for follow-up and they don't actually need a second injection.
Now, in follow-up patients, if they have no problem, whether you are giving the second injection?
Pardon me,
Suppose
sir?
in follow-up patients,
Yes,
there is
sir.
no epiphora,
Yes, sir.
everything is okay. Whether you will give to
No,
second
sir.
injection?
No,
No.
sir.
No,
But
yes.
we'll always counsel them that if they have this problem again, we can always give an injection.
Yes, yes.
So, how will rule out our lacrimal pump failure?
Lacrimal pump.
Pump failure in these cases. Lacrimal pump failure, because you...
Pump failure, sir.
Yeah.
Okay, sir. So in lacrimal pump failure, we basically do a fluorescent dye test.
Have you done it in this case?
Yes, sir, we did. Yes, sir. Syringing and a good fluorescence dye disappearance test. Yes. Yes, sir. infective component, we cannot give a Botox injection. So that was, no sir, no sir. Because in injection, sir, with a good syringing, because in an infective component, we'll always have a good amount of discharge, sir. Yes, sir. So in the lacrimal system, you're saying infection? Okay. So we did a syringing. In NLDO obstruction, we did not give any Botox. We advised for a DCR. Yes, sir. No, sir. We are not addressing the the system, basically the lacrimal system. We are just addressing the symptoms of the patient. Yes, sir.
So, Dr. Issa, this is a temporary treatment, yes?
Yes, ma'am.
So, you have to find out the underlying cause and go for a permanent treatment. This is a symptomatic relief only. You have to find out the underlying cause or etiology and when provide the permanent treatment. It is always a temporary treatment. So, counseling is very, very important for.
Ma'am, we did try to find out the cause. Maximum of our patients were common canalicular obstruction. And in common canalicular obstruction, they don't generally resolve with a DCR. And even the Jones
Yes,
tube.
definitely you have to go for some other type of surgery like conjunctivodactylocysterrhinostomy, tube implantation, etc. Yes?
Jones tube also we've done in 2-3 cases, but there is displacement in of the tube placement. So, like, this is an easier technique.
But
and
I think repeated injection into the lacrimal gland is not very
very advisable.
yes,
ma'am.
advisable.
We cannot give more than 4 injections.
Yes.
Ma'am.
Dr. Issa, why do you think that due to injection, botulinum injection to palpable lobe, there is a epiphora is less, means the symptoms are relieved?
Yes, ma'am.
Why do you think that that should be there should be no epiphora because of that?
So because lacrimal gland is basically the secretory part of.
No, because basic secretion is not by the lacrimal gland, palpable lobe or main gland. Basic secretion is by accessory lacrimal gland.
Accessory and.
So because you are not addressing the accessory lacrimal gland, so why do you think that epiphora resolved? There must be some hypersecretion then. So it is not actually a proper epiphora. There must be some hypersecretion part is there. Then only it will be resolved. So I think there is a epiphora term is not appropriate here. Okay. Thank you. Thank you, Aski sir. So we'll be coming to Dr. Kiran Bora. So he'll be having a presentation on a case of unilateral idiopathic inflammatory syndrome. Dr. Kiran, please.
Good morning, one and all. I'm going to present a case of unilateral idiopathic inflammatory syndrome. Introduction part. Idiopathic orbital inflammatory syndrome is a benign inflammatory process of the orbit with no known local or systemic causes. The inflammatory process may be both unilateral or bilateral, although unilateral is more common. It is a diagnosis of exclusion to rule out other causes of orbital inflammation like an infection, neoplasm, systematic autoimmune conditions. Now in my case, a 40-year-old female presented with swelling and forward bulging of the left eye from 2 months, which is associated with intermittent redness and gritty sensation. Secondly, pain in the left eye since 2 months, which is moderate in intensity and constant throughout the day. There is no history of illness like diabetes mellitus, hypertension, thyroid dysfunction, or any malignancy. Coming to examination, right eye finding was normal, within normal limit. In the left eye, visual acuity was 6/12, but the base corrected visual acuity was 6/6. And in the eyelids, there is mild swelling of the both upper eyelid and lower eyelid, and the conjunctiva, there was mild congestion. Others are within normal limit. Examination of the left eye shows the orbit axial proptosis. When doing a Lewis ophthalmometry, 23 millimeter axial proptosis of the left eye is seen, and 18 millimeter in the right eye was seen. There was no change in size with Valsalva maneuver or cupping or straining or change in the head position. When doing trans-elimination, there was no trans-elimination positive. Compressibility, it was not compressible. No orbital thrill was there. It was non-pulsatile. On auscultation, there is no breath present. Extraocular movement, extraocular muscle movement was full in all cardinal cases. Mild tenderness around the eyeball. Based on the history and the clinical examination, provisional diagnosis was made as it is a case of unilateral axial proptosis due to idiopathic orbital inflammatory syndrome. Now, when doing the investigation, blood routine investigations, it was within normal limit, including the thyroid function test and all. When doing the ultrasound B scan, a well-defined hypoglycemia noted in the retrobulbar region, which is causing mass effect on the globe. And while doing contrast MRI of the orbits, a well-defined homogeneous lesion in the intraconal compartment of the left eye, which is pressure suggestive of idiopathic inflammatory syndrome. It involves the medial rectus, inferior rectus, and inferior oblique muscles pushing the globe anteriorly without any globe or extraconal extension. Final diagnosis was unilateral idiopathic orbital inflammatory syndrome of the left eye. Treatment was given intravenous injection of methylprednisolone followed by oral prednisolone in a tapered dose over a period of 1 month, which showed dramatic improvement. Other treatment was given oral pantoprazole till the oral steroid is continued. Thank you.
Thank you, Dr. Kiran. Any interest?
Hello, is there any chance of recurrence in your cases?
Yes, ma'am. Actually, the patient has came after 1.5 months to our department with the same complaint. Then again, we have started the methylprednisolone, another dose, and it is dramatically improved. Sir,
how many days?
Sir, we started injection methylprednisolone 1 gram OD for 3 days, and then subsequently we tapered for 1 month orally.
So you believe in a very huge dose, I mean, a big dose sort of. 1 gram daily. 1 gram daily is a big dose.
Yes, sir.
Big amount.
1 gram daily for how many days?
Sir, 3 days, sir.
3 days, then followed by the oral tablet.
Dose,
Yes, tapered dose for 1 month.
Yes.
Oral prednisolone or Medrol?
Methylprednisolone.
Medrol.
Yes.
Okay, for how many days?
1 month, sir.
1 month.
Yes, sir.
In what dose?
60 mg, sir. Our body weight was 55
1
kg.
milligram per kg?
Body weight, sir.
Per day?
Yes,
Okay,
sir.
that applies to prednisolone actually.
Yes, sir.
That more applies to prednisolone, that calculation, I mean 1 milligram per kg per day. Okay, anyway. And did you give a coverage of some antibiotics?
Yes, sir. We have given ciprofloxacin 500 milligram BD, sir. BD dose.
Outcome?
Actually, ma'am, when she presented, her left eye vision was 6/12 and 6. When we corrected, base corrected visual acuity was 6/6, ma'am. Optic disc in the optic disc finding, there are some choroidal folds was there, but others are optic discs are perfectly normal. Correct. Yes, ma'am. Because it is a steroid responsive case, that's why we are not planning for biopsy. If the case again comes, or if the steroid becomes steroid unresponsive, we will plan for accordingly histopathological examination.
What kind of biopsy do you plan?
Ma'am, actually, we will plan for excisional biopsy.
Intraconal?
Intraconal. FNSC we can do.
FNSC.
If I somehow missed, I don't know, maybe I have missed. Did you get some investigations done, something like MRI or something? Was there any compression on the optic nerve retrobulbar?
No, sir.
Nothing like that?
No.
It was
No,
clear.
sir.
I mean, you got
Yeah.
some MRI or something done?
Yes, we have done it, but optic nerve was perfectly normal. There was no compression, sir.
Okay.
No, ma'am. Yes.
Okay, thank you, Dr. Kiran. So now we'll be having Dr. Pranaya Vaishyak. She will be presenting endogenous endophthalmitis following endocarditis, a case report. Dr. Pranaya, please.
Hello. Good morning, everyone. I am Dr. Pranaya Vaishyak from Barbata Medical College, and today I'll be presenting a very serious medical condition which might first present in our opthal OPD, and as a doctor, our duty to diagnose it and refer it to the medicine department for proper treatment. My case, she was a 14-year-old girl who she presented in our OPD with acute pain and diminution of vision of her right eye. She also presented with high-grade fever with chills and joint pain since 2 weeks. Her diminution of vision and acute eye pain was around 1 week to 10 days. We have repeatedly asked her if there was any trauma or any ulcer, whitish discoloration of her eye, or any she got any foreign body into her eye, but she gave no such history. She was also a normal girl without any diabetes or any hypertensive or any systemic previous history. But when she first came to our OPD, she was having a very poor general health. Her sleep, appetite, and all her bowel movements, everything was disrupted. And then after her examination, we found that in her right eye, as you can see, there was mild swelling of the eyelids, there was congestion of the conjunctiva, and there was mild discharge. Then, but when we did fluorescence staining of her cornea, there was no defect. It was perfectly okay, but there was a thick hypopyon on the first day, and there was a thick hypopyon on the anterior chamber. And when we assessed the vision, we found that it was PL doubtful with inaccurate PR. She first used to say that she has seen the light, then she used to say that she cannot see the light. Even but when we checked her left eye, it was normal. We admitted her in our ward, and we started her on topical antibiotics like general, which we used, like moxifloxacin eye drops. Then we even started her on cefixime 200 milligram BD. Then we even gave her some antifungals to rule out any fungal contamination. Then cyclopentolate was also started. But later on, as she progressed and she was in our ward, there was we checked her with a direct ophthalmoscope. There was no fundal glow, and we found out that it must be, we thought that it must be a full-blown endophthalmitis of her right eye. Then we advised her for B scan, and we even gave a medicine consultation. From the medicine side, when they examined, they found that there was a pansystolic murmur on her left sternal border, and they gave all her blood tests like CBC, RFT, LFT, and even they must have suspected some kind of endocarditis or something like that, so they even gave her an emergency echocardiography. Then her blood tests came out normal, with slight increase in RBS. It was around 140, 145, and but her ESR was very high. It was 110 millimeter in first end of 1 hour. Then we even did her RA, rheumatoid arthritis factor, and it came out negative. Then we sent her for blood culture, but blood culture takes about 48 to 72 hours. But we had started her IV antibiotics. Even though she belonged to the very lower socioeconomic strata, she couldn't go for echocardiography, but still we have done her echocardiography, and there vegetations of the MR valve, it came out. So then they suspected endocarditis, infective endocarditis from the medicine side. Then we shifted her to the medicine department from our side, since her vision was already PL negative, and she was highly toxic, and there was fever and all. So we thought that any ocular intervention will deteriorate her general health. So we have shifted her to the medicine department. Then in the medicine department, we followed her up, and there she was started with ceftriaxone and sulbactam. But after 2 days of IV antibiotics, she improved. Like her fever decreased and her joint pains has decreased. Not completely decreased, but it is not completely gone, but it has decreased to some extent. And when I checked her, again her vision was PL negative. So there was no point in doing any ocular intervention. Then from the medicine side, because she was having a mitral regurgitation and her pansystolic murmur was there, so since we are, I'm from Borpeta Medical College, so they thought that they will be referring her to the CN Center Guwahati. She was referred there, and for any further, any valvular disease is there or any some kind of other treatment was required, so she was sent to the CN Center. But even her, after she was sent there, so we thought of following up, but she did not follow up, so I'm very sorry. And but she was getting treatment. Even when I called her up, then she was getting treatment for this cardiac complications. And but I'm sorry to say that she did not follow up with her other reports, and we could not follow her up for any eye intervention. Thank you.
Thank you, Dr. Pranaya. Any introduction, please?
Yeah, Pranaya, it's a case of endophthalmitis.
Endophthalmitis.
So what is the relevance of endophthalmitis with your corneal findings? There is
Sir, mostly endophthalmitis in the common setting, it mostly occurs because of any exogenous.
No. You are presenting a case of endophthalmitis. What is the relevance of writing
Sir,
here?
there was no
corneal
defect. There was no corneal defect.
And what is the relevance of giving an antifungal, topical antifungal?
Sir, it was
So you should be precise. First thing is that it is a case of uveitis.
Uveitis.
Then when you dug into the deep, then it is a case of endophthalmitis. So it is a case of endogenous endophthalmitis, and you have to rule out the infective focus. Is there any Osler's note?
Osler's no, sir.
Is there any other peripheral findings, other findings of
Sir, from the medicine side.
Have you isolated the Streptococcus viridans?
No, sir. We have sent for blood culture.
So
Blood culture.
These are the typical points that you should include in your presentation. Thank you.
Yes, ma'am. We thought of doing all this, but because she was very toxic and there was high-grade fever and she did not give consent for any, even we couldn't check her IOP because she was in pain, and so that's why we thought that it will be better for the patient, so we shifted her to the medicine department. And other eye was normal, completely normal. It was 6/6 vision, and there was normal fundus picture. Yes, sir. But we did her rheumatic, RA factor came out negative. Oh. So it is a grade 2 hypersensitive reaction to any streptococcal infection.
In childhood is the most common is the sore throat.
Yes.
So throat, did you go for any throat swab?
No, sir.
It should have been done because this child presenting with endocarditis, there may be a congenital anomaly, number one, because she has not presented so far. Now joint pain followed by endocarditis, so that this is a very common setting, rheumatic fever, that is a complicated rheumatic fever.
Yes, sir. We should have done that, sir. We should. So we have sent for the blood culture. Yes, sir.
That would have given you so many more information.
Sorry, sir. We could not get the. Yes, sir. Blood culture is the.
What we call as connecting the dots. So that will connect the dots. I mean, to go for a final diagnosis of, an endogenous endophthalmitis.
Endogenous endophthalmitis.
So we have to isolate the organism from whether it is from the skin lesions, from whether it is from the throat swab, but we have to establish that it is a case of endocarditis. So we have to isolate the organism. It's very important.
Yes. Yes. There was, sir, vegetations were found in the yes, sir. Yes, sir. Penicillin has a role, yes, sir.
And actually, just I want to tell one thing, that endocarditis may be because of fungal also. And that is why only bacterial culture is not sufficient for blood culture. You should go for even fungal culture. I know a patient suffering from endocarditis. He was given all sorts of antibiotics, systemic antibiotic. He was not improving. And after that, blood culture was given for fungus, and it came out to be fungus, and on antifungal only, he actually improved. So that's why endocarditis are both bacterial and fungal in origin. Thank you, Dr. Pranaya.
Thank you, sir.
Now we are having Dr. Pooja Devi. She'll be presenting Tolosa-Hunt syndrome, a hornet's nest.
Good morning, everyone. Today I am going to present a case on Tolosa-Hunt syndrome, a hornet's nest. A 14-year-old female presented with chief complaint of sudden painful loss of vision in the right eye and drooping of upper right eyelid for last 2 weeks. It was not associated with any discharge, watering, ocular trauma, or any ocular surgery. The patient had no history of any fever or any systemic illness like diabetes, hypertension. The general examination and system examination were found to be normal. On ocular examination, the visual acuity of the right eye was found to be perception of light positive, and PR was accurate. The extraocular movement was restricted in all directions. The right eye had moderate ptosis. On pupillary examination, it was found to be grade 1 relative afferent pupillary defect, and the fundus was found to have a pale optic disc. On left eye examination, it was found to be normal, and the visual acuity was 6.6. This is the picture showing the fundus photograph, showing pale optic disc, and the OCT was also done in the right eye, and it was found to be normal. Since Tolosa-Hunt syndrome is a diagnosis of exclusion, so we did all the blood investigations. Here we found that the WBC count was a bit high, 13,500. RBS was found to be normal, 65 milligram per deciliter. CRP was high, 14.70 milligram per liter. Viral markers were all negative, and a VDRL test, it was non-reactive. Chest X-ray showed normal finding. It had no abnormality. On CSF analysis, there were no Mycobacterium tuberculosis or cryptococcal antigens. Doing the contrast-enhanced MRI of the brain and orbit, it showed heterogeneously enhancing soft tissue at the anterior aspect of the right cavernous sinus and right supraorbital fissure with extents and relations which were suggestive of Tolosa-Hunt syndrome. There were no other clinically significant abnormality detected in the MRI brain. So we started with the pulse therapy of IV methylprednisolone, 1 gram per kg body weight for 3 days, and this was followed by oral prednisolone with tapering starting from 40 milligram per day. After 3 days, we found that the patient responded very well to the steroids, and we can see it evidently by the improvement of the drooping of eyelid and extraocular movement. Also, there was relief in the pain in the right eye. Since the patient already presented us with perception of light positive, and the optic disc was pale in the right eye, there was no improvement in the vision of the right eye. The patient is still under follow-up since last 5 months, and there is no recurrence seen. Thank you.
Thank you, Dr. Pooja. Any interaction, please?
What about the improvement of vision? Because you told the optic nerve is pale in your case.
Yes, ma'am. There was no vision improvement seen in this case. The patient had already perception of light. So we didn't see any improvement in the vision. Only there was improvement in ptosis and extraocular movement.
In this case scenario, how you evaluate the other causes?
So first of all, we'll see clinically, we'll see about the already pupillary sparing, then we will go for the
what is the most common cause of patient coming to the OPD with headache, pupil sparing, and muscle restriction? What is the most common cause?
So optic neuritis.
People.
So.
So all the nerves are culprit, and the nearby cavernous sinus is situated. Okay. So at least in this case, we should evaluate the MRI angiography. It's very common nowadays in the clinical practice. Thank you.
Thank you, sir.
Thank you, Dr. Pooja. Now we are having Dr. Namrata Sri. She will be presenting recurrent episcleritis with latent tuberculosis, a case report. Dr. Namrata, please.
Thank you, sir. Good morning, one and all. We have a case of recurrent episcleritis in a latent tuberculosis patient. She is a 60-year-old female from northeastern India which presented to our OPD with dull aching pain, redness, and lacrimation from her right eye since last 6 months, which was severe since last 15 days. She gave history of multiple episodes of similar symptoms previously, which was initially diagnosed with simple episcleritis and was treated with topical steroids from other institutions. Her symptoms were subsided but recurred many times. She had no history of any trauma or ocular surgeries. She is a known case of diabetes and blood sugar is well controlled with treatment. She was otherwise clinically free of any symptoms and her past and medical and surgical history was unremarkable. However, family history was positive for possible exposure to TB, as her husband was treated for tuberculosis 2 years ago and has completed the ATT course. On ocular examination, we have visual acuity normal in both eyes. Right eye had conjunctival congestion with engorged episcleral vessels on temporal side, which showed blanching and pressure. Rest of the structures were normal in right eye. Left eye had all normal findings. IRP was normal in both eyes. And on fundus examination, both eye has normal disc and vessels with good fundal reflex. On general examination, systemic findings were normal. In investigation, everything was normal. ESR, blood sugars were normal. RF factor was negative. CRP was negative. Chest X-ray did not give any findings of pulmonary TB, but Monto test was found to be positive with an induration of size 21 mm after 48 hours of injection. We came to a diagnosis of recurrent diffuse tubercular episcleritis of the right eye as Monto test was strongly positive. The treatment was started, eye drop moxifloxacin 0.5% with dexamethasone 0.1%, 1 drop 6 times in right eye for first 5 days, followed by 4 times for 5 days and followed by 2 times for next 5 days. Along with that, carboxymethyl cellulose was started 4 times in right eye for 14 days, and ATT was started from the medicine side. Patient was started on isoniazid, rifampicin, pyrazinamide, and ethambutol for the first 2 months, followed by isoniazid and rifampicin for the next 7 months. The patient responded well to the treatment and recovered after starting ATT, along with the other ocular treatments being given. No relapses or recurrences were observed over the 12 months of follow-up since completing the ATT treatment. In our setup in developing countries, TB is a highly infectious and prevalent disease causing high morbidity and mortality. Though it commonly affects lungs, but it invariably involves ocular structures. Ocular TB may involve the lid, conjunctiva, cornea, sclera, uvea, optic nerve, or orbit, mainly accompanying latent TB. Episcleritis is one rare manifestation of the disease that can present as simple or nodular episcleritis. The recent literature has few cases of episcleritis secondary to TB. This was further, our case, our investigation and findings points towards the TB as the probable cause. This was further confirmed by resolution of the patient's complaints after commencing anti-tubercular therapy. Even though tuberculosis has a rare association with episcleritis, keeping in mind the high endemicity in India, we suggest that tuberculosis should be ruled out whenever we counter a case of recurrent episcleritis. Thank you.
Thank you, Dr. Namrata.
Yes, nicely presented.
Thank you, sir.
The thing is that in recurrent episcleritis, you have done the Montos test,
Yes.
you know.
Yes.
So Montos test was positive. Whether you have done other tests, chest X-ray or other recent test to diagnose the TB?
So chest X-ray was done. It was found to be normal.
Normal.
No
And,
pulmonary
any other test?
So CBNAT was suggested, but she could not do.
She have not done.
No, sir.
So treatment started on the basis of Montos test only.
Yes, sir. We consulted the medicine department and the treatment was started from their side on the basis of Monto test only.
But we should diagnose the tuberculosis because other PCR test Yes. CBNet, etc. should be done in these cases before starting the treatment.
Yes,
And nowadays we find this type of cases, episcleritis or other disease, and recently I got one case of granulomatous hydrocyclitis, and it was Montos test positive, same like that. And it also, we advised for this recent test, PCR and CBNet, etc. But patient started the same treatment, whatever given in this. And your patient improved with the treatment?
Yes,
Improved a lot. So, nice. Thank you.
Thank you.
Thank you, Dr. Ramrutra. Next, we will be having the last presentation. Originally, it was from Dr. Desi Ranidas, but that will be presented on her behalf by Dr. Parmita Datta. So, she will be presenting outcome of descent membrane detachment repair in post-cataract surgery patients, a case series. Dr. Parmita, please.
Good morning, respected members of the panel and all the delegates present. I'm here to present a case series on outcome of descemet membrane detachment repair in post-cataract surgery patients. DM can detach from the posterior corneal stroma during many eye surgeries and lead to vision-threatening corneal decompensation. However, the incidence noted is very low. In manual SICs, only 0.1%, and in phaco, 0.04%. So here we report a case series of 6 cases of DMD that occurred after cataract surgery, and management was surgical, a combination of methods of air decimetopexy and DM suturing. We'll analyze a different approach in each case. Case 1 was a 68-year-old male coming with the complaints of POD1 vision after SICs to be counting figure close to face. Conservative management was given for this patient. However, at 1 month, DM suturing was done. A full thickness DM suture was placed. At 1.5 months, her post-op vision, however, was figure counting close to face at 50 meters, and the cornea went into decompensation. Case 2 was a 66-year-old female presented with POD1 vision after SICs to be 1/60. For her, combination of methods of DM suturing and air decimetopexy was done at 15 days of post-op. So on day 10, her vision was 6/6 parts. Here, the slit lamp picture, we can see that there was a evident DM detachment that was non-planar central in location, and depending on this optical section of the slit lamp, we underwent surgery for this patient. Case 3 was a 55-year-old female. At 5 days, her vision was 6/36 post-op SICS. For her, air decimetopexy was done, and at 1 month, her post-op vision was 6/6 parts. Case 4 was a 70-year-old male that underwent phacoemulsification elsewhere in the right eye. She came to us with a limbal-to-limbal DM detachment. So for her, a combination of methods of DM suturing and air decimetopexy was done. However, at 15 days, when we tried to remove the suture, corneal edema came back. So resurgery was done for her case. And at 1 month, her vision was 6/9. Case 5 presented to us a 60-year-old male. Right eye POD1 vision post-SICs was 6/60. For her, air decimetopexy was done, and her vision was 6/12 at 15 days post-op. Case 6 was a 70-year-old female, post-SICs POD1 vision was 6/12. For her also, air decimetopexy was done. Here also, in the optical section of the slit lamp, there was an evident DM detachment that was central in location, non-planar, and scroll type. And therefore, air decimetopexy was done, and at 1 month, her vision came to be 6/6. So discussion, 3 of our patients underwent DM suturing, and 3 of them underwent air decimetopexy. All cases had good anatomical outcome, that is good DM reattachment on the optical section of the slit lamp, and functional outcome, that is vision at 1 month was 6/6 in most of the cases, except one, the first case where cornea went into decompensation because there was extensive DM loss and endothelial cell loss, traumatic injury to the DM during primary surgery. So conclusion, slit lamp optical section is an effective method for diagnosing, monitoring, and guiding the surgical decision in DMD repair. However, prompt and adequate surgical intervention in correct time span helps in preventing further visual morbidity and saving the cornea from going into decompensation. Thank you.
Thank you, Dr. Paramita. Interaction, please.
Paramita, have you done the endothelial cell count?
No, sir, because most of the patients were from community background. So endospecular microscopy could not be done for these patients. However, on optical section, when we examined the endothelium, then it was noted to be healthy. And her
OCT?
Sir, OCT also we have done for only 2 cases. As I have already said, most of the patients were from community background. So they could not, yes, sir.
The main point is that you are representing an institute like C. Sankardevan Netralaya, and you are presenting a case series. But so we should, not only to you, all the panelists, and all the, I think as a college, faculty from the medical college, and there are stringent rules of methodology nowadays. So we should at least put the methodology part so that the study can guide you to a further another some kind of new results. So you have included 2 OCT, left another 4 patients. You do not have any endothelial cell count or any other kind of interventions. And the surgeon, there may be surgeon factors also. So we have to rule, okay, postoperatively, everyone we used to examine the patient and slit lamp. It is obvious. Okay.
So main
so methodology part, now my key point is that methodology part and the C. Sankardevan Netralaya is a premier institute in our region. So I think methodology part is a bit, I think it should be more stringent. Yeah. Thank you.
Ma'am, most of the patients were from community background. Camp cases were there. Therefore, ASOCT was not done in them because of financial constraints. Otherwise, the 2 cases they were paying and we did the ASOCT in them.
I think you should do in all cases when you suspect a detachment, yes?
Yes, ma'am.
Because otherwise, in our institute, we all do slit lamp examination, but especially when to decide the planned treatment part, you have to do a OCT, yes? Anterior segment OCT.
Okay. Thank you.
Dr. Daisy, sorry, Dr. Paramita, what do you think what are the causes of this DM detachment in those patients?
So during cataract surgery, if blunt instruments are used, the instrumentation technique, and if blunt instruments are used, then the DM can separate from the stroma and lead to DM detachment. Instead of perforating the DM, we are separating the DM from the stroma. And if there is excess hydration or overhydration at the side port region also, then it may lead to DM detachment. Most
yes,
common causes.
that is the most common.
Yes.
But what about the central DM detachment? You had a case of central detachment. I could not understand how it can happen.
Sir, it was referred from us from outside actually.
No, I know.
Yes, sir.
But what may be the cause that that is not actually understandable for me, that only central part of it is, I have not seen like that. Anyway, thank you for a nice presentation.
Thank you, sir.
So we come to an end of this rapid fire session. We had array of cases and presentation. So we almost all parts of the ophthalmology has been touched in this rapid fire session. And so we come to a conclusion of this rapid fire session. Thank you to all the panelists. Now I request our organizer to hand over a memento to the panelists. First, I would like to request the Chumur to present the memento to our chairperson, Dr. Mamani Burabaido. Next, our co-chairperson, Dr. Gautam Pal sir. And next, Dr. Rajiv Das. Last. Thank Thank you everybody for this participation. Participants and all audience, thank you. Next I hand over this mic to Dr. Abhijit.
Thank you. Because of many small reasons, we are running behind time anyway. Let it be a little relaxed morning. We are now going to have a very interesting session. That's the video theater. To conduct this, I request Dr. Shamanta Borua in the dais as a moderator, and I request Dr. C.K. Borua sir to come as a chairperson, and Dr. Bharati Samma Pujari ma'am also as a chairperson. And to declare it's not a competitive session, so the chairpersons and moderators will give their comments, and maybe from the audience also. So let us start with the first presentation of Pranab Kalita.
Thank you.
Good morning, ladies and gentlemen. I am told by the Chairman Scientific Committee that we are running about almost 1.5 hours late of the session. So I request all the presenters to keep the time limit very strictly.
Yeah, good morning all. It's a privilege and honor for me to be the moderator for this session. For all those of you who do not know me, I'm Dr. Shamanta Borua, Associate Professor of Ophthalmology, Jorhat Medical College and Hospital. And I'm proud to be with the stalwarts like Professor Retired Dr. C.K. Borua sir and Professor Retired Dr. Bharati Sharma Pujari Madam. We're running short of time, 1 hour almost. So request, as sir already said. So we should immediately start. Dr. Pranab, please start.
Good morning. This is a case of chronic angular glaucoma post-keratoplasty. This is a very interesting case basically. This patient, he was, can I start the video please? Yeah. So this patient had bilateral corneal dystrophy, and he underwent okay, I will explain the process. So after the subdermal anesthesia, I have marked the 2 points between the superior rectus and the lateral rectus for the superior temporal placement of the Ahmed valve. In the sense that this is a post-keratoplasty case, the distance between the cornea is very less and the IOL is very less. I cannot, so I am priming the Ahmed valve. Yes. Then 1 week before, the patient underwent pars plana vitrectomy with capsulectomy. The IOL is already there. So I had no donosclera. So this is a technique I am using. Without donosclera, I will be putting the Ahmed valve. So after the traction suture and the placement of the 8 mm distance, I am making the suture marks, pre-placed sutures. Yes, so this is the distance in which I want to make a flap. So I don't use donosclera. Basically, I put all the Ahmed valve, the tubes, under flaps. Because in my experience, I've never seen any flap exposure of the tube so far. So now I am dissecting the scleral flap. Is almost 5.5 millimeter in length. Yes. So after that, I a strip of sclera by using the crescent blade, so that I will hide the tube. I will pass the tube through it, so the tube is not exposed. This is a technique I am using to avoid use of donosclera. Now I am putting the Ahmed valve there. I am suturing the fixing with Ahmed valve with 6-0 silk. Now I'm passing the tube through under that skull belt. Yes. And I'm taking a distance of about 4 mm from the limbus. That is the distance, and this is the midpoint through which the tube will go through. So I'm cutting about 3.5 mm, and there I am using the 23 gauge cannula needle to make the entry. Now I put the tube into the vitreous cavity, and I'm using this suture to press down on this tube so that it never has the chance to move. These two things, the belt as well as the sutures, will always keep the tube pressed down. There is no chance for any tube exposure. After that, I am fixing the conjunctiva purse-string suture by using H0 Vicryl. And the eye seems I'm taking the eye seems quite soft. Now giving a subtenon antibiotic dexamethasone injection, and I'm closing the case. So this patient did very well post-op. Yes, okay. Post-op the IOP was 10 mm, and it has been persisting in that 10 mm in for the last, it was 3 months post-surgery, and he's doing pretty well. And this is a one-eyed patient basically, and this is the only thing that could have saved the eye from vision loss, because the IOP was almost 45 mm Hg with Diamox and anti-glaucoma topical medication. So I had to do something. To save the vision and control the IOP. Thank you.
Thank you, Dr. Pranab. You have really presented the topic beautifully and very meticulously have covered everything. Dr. Pranab is doing great work on glaucoma in Jorhat and around. And we are thankful to him for introducing this new technique of Emmet glaucoma valve, although it's already being done regularly nowadays, and it has been established as a very useful option for refractory glaucomas, I guess. Yes. Okay. Thank you so much for your beautiful presentation. I hand over the mic to our respected chairpersons.
Actually, what is the follow-up period of this?
This patient actually, the last follow-up I told you is 3 months post-surgery.
What was the IOP control like?
10 mm Hg without any medication.
Without any
medication, right?
10 mm.
10 mm Hg. And he's doing pretty well. Initially the IOP was almost 45 mm Hg without any, because this was a case of corneal ulcer post keratoplasty. This was a therapeutic PK done in an outside center, and in these cases of fibrinous uveitis and keratitis, the iris is very sticky. It just closes the angle. There is no space basically. I had to do something to drain the aqueous out from the vitreous cavity. There is nothing intervention you can do in the antechamber. Because most of the cases of AGV, many are placed in the antechamber. But there is no space. And I cannot risk corneal decompensation at any cost, because the valuable graft.
That's fine. Now, are you aware of this very long complication of this procedure, especially in case of sort of compensated eye with keratoplasty?
No, because since the tube is in the vitreous cavity, there is no chance of any tube corneal touch. It is behind the eye well. So if the eye is well controlled, this graft will survive for long. I mean to say, its natural history. The intervention has not produced any corneal touch. So the chance of corneal decompensation post-surgery is very less.
Any idea of having the long follow-up series of this type of patients?
Sir, since I have given AGVs around not that much, around I think 20 to 25, because these cases are quite rare, and this type of refractive glaucoma is quite rare. And with advancement in trabeculectomy, due to FAIR, they do very, very good. But these cases are cases that need AGV intervention.
Very good. Thank you very much, and I congratulate you for taking up this type of surgery, especially in the
I have my colleague, Dr. Prasanto Soikia, he's a VR surgeon, and with his help, actually, with his being around, I will do this.
More confident,
You
yeah.
are more comfortable with VR surgeon around.
Yeah. Dr. Pranab, please enlighten us on the durability of this Ahmed glaucoma valve.
I have series of around, I would say, 10 years, because it is almost like 13 years in Chandraprabha. 10 years I have seen AGVs doing very well. The IOP seems control almost around like 15 to 20 without any medication. It's very well. And patients do not have any dysesthesia. They do not have any like restriction of movement. No, they don't feel anything. Initially there is some, but after long years they don't feel anything, and it's a very good thing actually. Savior of the eye, I would tell you.
Hello, Pranab, you are doing excellent surgery, which is very good. But I'm asking why you are taking this, the same, this cornea, not taking the scleral graft.
Because, madam, the scleral graft, basically you need to have an eye bank. Eye bank, and in our hospital at present not doing well. And the most important thing is that without any like lot of, for giving something graft, there has to be like test, mandatory test, and the viral markers should be done, and I don't want to risk anything. Because this is one-eyed patient, I don't put something like a unknown infection in that eye. So, and that is the reason for which I have never used graft so far. Initially 1 or 2 cases, but in my experience, this scleral, the scleral patch I make, the flaps, they do very well because the patient's own tissue, there is never any chance of necrosis.
Thank you so much.
Thank you very much, Dr. Pranab. And quickly, anyone from the house, if you have any queries, because we have to really proceed soon. I mean, we are running very late. Quickly, anyone from the house, or otherwise we can call the next speaker. If there is no one from the house, I request, yes? Okay, now I call upon Dr. Gitumani Sharma, DNB. She is a vitreoretinal surgeon, UVA and ROP consultant, ASGI Care Hospital, Paldan Bajar, Guwahati. She will speak on scleral buckle with subretinal fluid drainage, the technique. It's an art. Please start.
Scleral buckle with subretinal fluid drainage, the technique. It's an art. This algorithm shows mostly scleral buckle is the first line of treatment once there is retinal detachment, which is shown in this video. A 6-snip technique of conjunctival opening with relaxing radial incision will give a clean opening incision. Horizontal radial incision is to be avoided to avoid the muscles. Separation of the tenons is done by blunt dissection. Isolation of the muscles done in order: inferior rectus, then lateral rectus, then medial rectus, and then superior rectus. Superior rectus is not to be hooked from the nasal side to avoid hooking the superior oblique fibers, which passes from nasal to temporal. After inspecting for areas of scleral thinning, break is localized and managed. Here is shown number 42 band 360-degree encirclage. Tying is done in 1 quadrant away from the break. Buckle starts 2 muscles away from the tying quadrant. Suture bites goes 1.5 mm anteriorly and 2 mm posteriorly between the 2 muscles, placing the buckle in the equator. This is to be decided by the surgeon depending on the height of the buckle needed. In 1 quadrant, you can see my left hand giving the suture which is required during buckling. Need to be careful in this step not to pass the needle full thickness at any point. This is very important. comes subretinal fluid drainage. Here is shown one technique of external drainage. To select drainage site, criteria are sufficient subretinal fluid, avoid areas treated with cryo, vortex vein and large break, should be above or below lateral recti, nasal quadrant and beneath the scleral buccal. Form the globe. Do a beautiful closure. After all, what anyone can expect more if the retina is settled the next day.
Thank you very much, Dr. Gitumani Sharma, for a beautiful video presentation.
Thank you, sir.
Before I hand over the mic to the respected chairpersons, a small question. I mean, up to the buckling, it's an extraocular procedure, but the moment you do the scleral incision for the drainage of the fluid, I mean, it makes the whole surgery an intraocular surgery. So how do you address that part? I mean, the infective issue, the uveitis issue, everything.
Yes, sir. Actually, that's why I had termed it D technique. Subretinal fluid drainage, we have to be very careful. We are only into the subretinal space. We are not going inside. So it doesn't become fully intraocular because we are yet to go into the vitreous cavity. Once you are into the vitreous cavity, that is the complication of the surgery, and you have to deal with like you have to go do the vitrectomy in that case. So you have to be very careful in this step only.
So that's the message. Maybe we can take that. That is the ultimate step where we should take utmost care. Thank you very much. I hand over the mic to our respected chairpersons.
Yeah, Dr. Gitumani, thank you very much. After a long time, I have seen retinal detachment surgery procedure from the external side. In the 1980s, we used to do this procedure a lot of time. But regarding the drainage of the subretinal fluid, there are certain specific indications of draining the fluid. All the cases, we don't need to drain the fluid.
Yes, sir. I agree with you, sir.
And can you enlighten the audience with that, where you will drain and where you won't drain?
Yes, sir. Drainage is done where we find that there is significant amount of subretinal fluid. When we do the indirect ophthalmoscopy pre-operatively, and if there is significant bullous retinal detachment, in those kind of cases, we go for subretinal fluid drainage.
Yeah. And another, you will have to take precaution is that when the detachment is quite big and there is a lot of subretinal fluid, and if you drain, quite a huge amount, I should say a huge amount of fluid, it will give some other complication. For example, tightening the buccal, and there is ocular hypotony in all these things. Did you face these things?
Yes, sir. There will be significant hypotony as shown in this case also. Significant amount of subretinal fluid that came out during the procedure. So before tightening the buccal, I ensure that the globe is formed with I do give gas sometimes. So either gas or sometimes I give fluid also to form the globe before I tighten the final closure is done.
Yes. And another thing is that I saw some choroidal tissue popping up through that sclerotomy hole, and that may lead to bleeding inside the eye sometimes.
Yes, we have to take care of all the complications which may happen.
Anyway, thank you.
Thank you so much, sir.
Hello, Gitumani. You are doing this excellent surgery. Just I want to ask you, what are the precautions you will take during this procedure of draining the this subretinal fluid? as Sir has already mentioned, no? So
Yes,
what
sir.
are the precautions you must be taken?
The most important thing I have to be careful during doing the drainage is that my needle should not go more than, like once the subretinal fluid, even if one drop comes, then I should stop going more deep. My needle should not go more deep than I required. I had pre-planned, like buccal surgery has to be pre-planned. I had pre-planned how much my needle should go. That is the most important point. And if the needle goes little bit more than how much is required, then there will be complications. So we have to be careful about that.
What knife do you prefer to do the drainage? Many prefer the crescent.
Crescent, I have shown a crescent. I do with crescent for the opening, but then pricking with a needle only.
Okay. Thank you very much. Anyone from the house? Quickly, or otherwise we can move on. Yeah, please. Yeah.
Good morning. Getumani, I just came at the middle. She has nicely presented. Regarding the question, how much the needle will go, the first thing is that it should be in a tangential manner. You should not directly prick.
Yes.
You have to give it a curve manner.
Yes.
So that you do not go beyond that corridor.
Yes.
So that is first point. And the constant pressure should be there. And you will stop at that point when you see some pigment is coming.
Yes, yes.
Thank you.
Thank you, Dr. Satanda. Next, I call upon Dr. Isha Agarwala from Dristy Netralaya. She will be presenting us with a very interesting yet very easy to learn topic, I should say. That's the double modified sewing method technique for iris repair. Please, Dr. Isha, start.
A very good morning once again to respected members of the dais and the audience. So my topic would be double modified sewing method technique for iris repair. And our aim would be to report a very novel, simple, effective, yet an economical technique of iridodialysis repair with a very, very short learning curve. So the purpose of this study is to report the double modified sewing machine technique for iris repair and its usefulness where a 10-0 proline suture with straight needle is unavailable. So in this type of method of iris repair, we can repair all kinds of iridodialysis. The first one is an extreme dialysis, second is a short dialysis, third one is a medium dialysis. With this method, we can repair all kinds of dialysis.
Today we had a case of inferior iridodialysis which occurred during a cataract surgery by a fellow surgeon. So in this case we had a 8-0 curve needle and we were unable to thread the 8-0 curve needle. So what we did was we cut the needle, we threaded the suture through a 26 gauge needle up to a certain extent so that we could take 3 bites from the damaged iris inferiorly. The suture was threaded well along its length in the 26 gauge needle so that we had adequate suture inside the needle. After it was threaded, what we did was we took the first bite through the tunnel, taking the inferior iris, the last edge of the inferior iris, we sutured it to the sclera. After that, we took a second bite next to the first bite and a loop was formed next to the first bite. Then the 26 gauge needle was taken out. The third bite was taken from the inferior edge of the damaged iris. From the needle was taken out to the sclera. And now we had 3 ends of 8-0 nylon suture. So now the middle suture had a loop. The loop was cut in between. And now we had 4 ends of 8-0 nylon suture. So what we did was we did a crisscross suture of the nylon ends. The third suture was sutured to the first suture and the last one was sutured to the second suture. And now we had sutured the complete inferior iorodialysis to the scleral spur. We now had a round pupil. Now the suture were covered with the conjunctiva. Thank you.
Thank you, Dr. Isha, for this beautiful video. What we understand from this video is that this procedure, this technique is very interesting, yet appears very simple, very easy to learn, with minimal instrumentation, I guess, and also probably very economic for so many situations like, I mean, anything about the iris when there is either dialysis or maybe, I mean, a post-traumatic or post-surgical iris pathology, I mean, where there's a tear or whatever. So it's very useful, and it should be really taken up. I mean, it can be done even in the periphery and the intermediate hospitals, not even the tertiary ones. So, and it's really sometimes post-surgically and even otherwise, say post-traumatic, etc. So I think it should be a very nice take-home message to all of us. Thank you very much. I hand over the mic to our respected chairpersons.
I've got nothing to say, but as Samantha has told, that it's a very good procedure, especially under the situations, and one can master the technique. It's not very difficult to do.
Yes, sir.
Congratulations.
Thank you.
Very nice presentation, Isha.
Thank you.
But I just wanted to ask, what is the advantage of doing these techniques over the cobbler technique?
Ma'am, the advantage is in this technique we can address any degrees of iridodialysis. Like if it is inferior, if it is temporal, nasal, any degrees. And at times we don't have a straight needle, proline suture, nylon suture with a straight needle. In this technique we are basically cutting off the curved needle, and a suture 10-080 nylon suture or proline suture with a curved needle is available in any center. So basically we can use any kind of suture having a curved needle as well, and we just need to thread it in the 26 gauge needle. That is the good part about this technique, and an easy technique which is which can be mastered in any type of setup.
Suture will not disturb any this one?
No, ma'am. Nylon suture will not disturb, ma'am.
Okay, thank you. Thank you so
Thank
much.
you.
Thank you, Dr. Isha. Anyone from the house, very quickly?
Thank you, sir.
Readily available, right?
It is readily available, but I'm showing for setups who don't have a VR setup. And that...
No, even though VR means that McConnell suture with a straight needle both sides, it is readily available. Yes.
At times it is not available in some setups, maybe. But I said because this suture is available at any time. A curved needle suture. A straight needle may not be available. It was available in our setup, but I just wanted to do with this. Yeah.
Okay.
Thank you, ma'am.
Confused which part you have taken out, which part tied. No,
Yes,
a schematic diagram side by side would have been better. Thank you.
Agree with you, Dr. Pranab. Thank you. Yeah. Now the much awaited, our next speaker, our very dear, dynamic Dr. Abhijit Kumar Handik, who will talk on tele-ophthalmology, our experience during COVID-19 lockdown. Abhijit, please.
Good morning, respected audience, moderators, and the chairpersons. As this is not a surgical film or that kind, it's a thematic film, let's go ahead with the presentation. I shall give my comment at the last.
Every patient and every doctor during Corona has a story to tell you, because we are
that's all. Just I want to highlight one thing, that in many hospitals, they say it's a teleophthalmology is what they create a network to the vision centers. In the vision centers, optometrists stay, bring in the patient, click the photos, send it to the consultant at the nodal center. They give the feedback. That I believe is not the teleconsultation. Teleconsultation is being in there, open it to the public. The public will grab your service, pay you, give their photos or videos or communications, then you respond. It's been there in many hospitals in other specialties, but I don't know how much is there or relevant in regard of ophthalmology, but this was our experience that I wanted to share with you.
Thank you, Dr. Abhijit Da. You're a very lovely and soulful video, I'll say. In fact, your video speaks a lot, much more than what you spoke. A very touching, heart-touching video. And indeed, that time, the COVID times, we call it, was a time for all of us to introspect, to know us, our beside. And the best thing that happened was that the world became one. We became one family, one people, one race, one mankind, one planet only. And another good thing that happened was probably the improvement of our digitalization, the internet. We could connect sitting at home, and things were really improvised and improved. And now we are having, we are much more than what we were before COVID times. Thank you very much. I hand over the mic to our respected chairpersons before we end this session, the video session. One more is there, but it's not in my list. Anyway.
Yeah, Vijay, it's a nice presentation. Out of all the odds of COVID, we learned or we gained something from the COVID also. Out of that sort of health consultation and advice by what should I say, by the net and or yeah, that's another good thing that has come up. And many people are still continuing with that, not only in the field of ophthalmology, in other fields also. That's a common procedure now in many aspects. And the teleophthalmology, it's not only from the COVID, it's from long back, it's there. Because as you mentioned, the different vision centers and all that, they are connected, especially in case of diabetic retinopathy screening and all these things. Teleophthalmology is helping a lot. And I think it's a good beginning even for the consultation. You need not, the patient, you save lots of patients' time, lots of patients, the consultation can be done. And as you said, around 20% of the patients, they need physical examination. Yes, they will need physical examination that we will have to do. Anyway, it's a good beginning. Thank you. Thank you.
Yes, thank you, sir.
Abhijit, it is a very, very beautiful video you have shown. It's talked a lot to us, and we memorize these days, really. That was the day where we have to, we are not practicing the telemedicine in all cases, but sometimes by the communicating with the photos and videos, we are helping a lot to the patient. Thank you so much, Abhijit, for your kind, so beautiful presentation.
Thank you, ma'am.
Anyone from the house, quickly, if any? Otherwise, we'll move on to the last presenter. She's Dr. Kartika from Chandraprabha Eye Hospital, Jorhat, and she'll speak on portable dark room for retinoscopy at eye camps. Please start, Dr.
A very good morning to respected members of the dais, audience, and my dear friends. I am Dr. Kartika, fellow from Chandraprabha Eye Hospital. So I'm here to present a very simple but very effective video of portable dark room setup for retinoscopy at eye camps. It is very effective, cost-effective, less time-consuming, portable, so that it delivers accurate and very effectively we can do the retinoscopy at eye camps, because eye camps are usually set up at rural and unreached areas. So we'll see the video. Thank you.
Thank you for your very important presentation, Dr. Karthika, very interesting. I liked it absolutely from the beginning to the end, but the best part that I really appreciate is not the technique, not the procedure, how you're doing, the method, how you're doing it, but the importance that you're giving, the due importance that you're giving to retinoscopy, which is sort of gradually getting obsolete nowadays, which should not. It's just like, giving up mathematical tables when we have the computer, when we have the calculator, when we have the mobile handsets on our hands. So I appreciate CPEH. I can see Dr. Narayan Bordale, sir, director, and I can see you. That's what I'm telling you. So I miss you, sir. You were supposed to be here with me today for this session. You were late. So Burwa sir took over. Thank you to all of you. Anyway, I appreciate that you are still maintaining with the retinoscopy, and this message should go to the PGTs sitting out there, that with the arrival of AR, autorefractometry, you should not give up retinoscopy, wet retinoscopy. And in our Jorhat Medical College and Hospital, in the ophthalmology department, we really insist our PGTs, if not daily, at least to do wet retinoscopy at least 2 to 3 times a week. I have our professor and head, Professor Dr. Gautam Paul, sitting out there in the first row there. He also, both of us, we try our best to implement that. That wet retinoscopy should be continued, at least to know forever. I mean, I hand over the mic to our chairpersons, and quickly we'll have to wind up with this video session so that we can go ahead quickly, fast. Thank you, sir.
Yes, as Samantha has said, retinoscopy was a very integral part of our training and our day-to-day practice in our times, when you used to do retinoscopy with a mirror and a bulb. But from then, it not only gave us the power of the eye, but also certain other things like your opacity in the media, whether it is in the cornea, lens, in the vitreous, like that. But I beg to differ a little with Samantha in this regard, that when the new things are available, and it is available everywhere and with all, so what is the scope of doing a manual retinoscopy? Anyway, it's a thing there. One has to learn it if this streak or autoref is not available. Anyway, and it's a good endeavor of doing, setting up a portable dark room in the camp setup. Thank you.
So it is a very good presentation. It is really needed. We needed the dark room in the camps. I have experienced that one in the Arvind Eye Institute, Madurai, and they are doing, in the 1994, I was there, and that I have seen, they made this dark room, and they give the benefits to the people of the villages with the dark room doing the refraction, and they are very happy because most of them, they cannot come to the main hospital, and they are having this the vision problem for a long time. So I think it is an integral part of the camp.
Yes.
Thank you.
Yeah. Yeah, Dr. Pankaj, yeah, please. Yeah, so that's the academic aspect of the whole matter, yeah. Yeah. Thank you, Dr. Pankaj, thank you very much. Now a little bit of felicitation. I would like to also, Dr. Jumu, Dr. Dipsika. Thank you very much. I always thought myself to be a tall guy, but now I'm short. Thank you all.
We are now going ahead with a free paper session. I request Dr. Pankaj Borua to take the chair as the moderator. In place of Dr. Kasturi Bhattacharya, I ask Juti Bhaiya Madam to take over as chairperson, Dr. Viman Saikia and Dr. Gori Gogoi as the co-chairpersons in this dais. It will be a competitive round. And I hand over the mic to Pankaj to go ahead with the session. And I request all the presenters to strictly maintain the time. We are already running late, but for the sake of academics, we are not restraining very much. But this time, we have to do it because it's a competitive session, and so you stick with your time.
So we are going to start the free
sorry. So there are two more additional announcement. The announcement is that any OSA members who have not received the journal can collect it from Dr. Haimanti. You just contact her. You will get a journal of JORP. You will get it from her. And second announcement is that there is a squeeze in the Yoshi where there will be a preliminary session. After this free paper round is over, there will be a very 5-minute, very short preliminary round where this preliminary of the squeeze will be held. So that will be conducted by Dr. Dipanjan. He will guide you around. Yes.
So we are now going to start the free paper session. So all our participants please can present your paper comfortably, but please stick your own time. So going to the first paper, under vitreous hemorrhage, everything to explore. That will be going to present by Dr. Gitumani Sharma. Dr. Gitumani Sharma, you can start.
Good morning, everyone. Underneath vitreous hemorrhage, awaiting to explore. I don't have any financial interest. What are the doubts in vitreous hemorrhage is, despite recent improvements in ophthalmologic diagnostic examination techniques, a vitreous hemorrhage often presents a diagnostic and treatment challenge. What is not known in vitreous hemorrhage is the incidence, which is caused by the PVD, vitreous hemorrhage due to anticoagulants, and whether intravitreal anti-VEGF in vitreous hemorrhage is beneficial, and whether we need to wait for 3 months as conventional belief before vitrectomy is to be done. So taking into account all these doubts, I have undertaken the study with the aim to find out the prevalence of non-resolving vitreous hemorrhage, to find out the etiological factors for non-resolving vitreous hemorrhage, the outcome of treatment in the form of visual acuity, IOP, and any further required interventions. It's a prospective interventional analysis, and approval from the IEC was taken, sample size calculation was done. The inclusion criteria was age more than 10 years with dimness of vision for more than 3 months for the first time at presentation, and after thorough ocular examination, diagnosed as non-resolving vitreous hemorrhage. Exclusion criteria were any previous ocular surgery, any complications after vitrectomy which needs additional intervention. Standard OPD examinations were done, standard investigations were done, and blood pressure was measured in each case. All the patients underwent standard 25-gauge pars plana vitrectomy with posterior hyaloid detachment wherever possible in constellation vitrectomy system with VOC minicord XL wide-angle viewing system with stereoscopic diagonal inverter with video recording of each of the procedure, and the follow-up were done in 1st, 5th, 14th, 25th, 45th post-operative day. Statistical analysis were done as standard, and p-value less than 0.05 was considered to test the level of 5% level of significance. What are the results? There were 61 eyes which followed a normal distribution data, and the male is to female ratio was 48:11. Mean age of presentation was 50 to 54 years. The age distribution where the number of vitreous hemorrhage was maximum was in the age group of 41 to 50 years. The presenting complaints was dimness of vision in majority of the cases. The mean duration of presentation after appearance of symptoms was 47 days. 9 eyes here are outliers, which values were more than 240 days at presentation, and 3 patients had more than 3 years of time of presentation, and the post-operative visual acuity remained the same after surgery in these cases. Intravitreal anti-VEGF pre or intraoperatively was not used in any of the PDR cases undergoing surgery. Now, there are some secondary outcomes which I had seen. That is, first wonder is NIDDM with vitreous hemorrhage was more, that is 31.14%, and IDDM with vitreous hemorrhage were less. Second wonder was all the diabetic mellitus vitreous hemorrhage were not because of PDR. And the third wonder was diabetes mellitus vitreous hemorrhage was for BRVO in 4, CRVO in 1, and incomplete PVD in 2 eyes. And most of the cases of vitreous hemorrhage were PDR, that is 42% in my series. So vitreous hemorrhage, if operated on time, can even have 20/20 vision post-operatively, as you can see in this photograph, from hand movement to 20/20 vision. I had 19 cataracts, but only one of them needed simultaneous phacoemulsification surgery, and none of the cases were asked to stop the anticoagulants which they were taking prior to the surgery. Mean preoperative visual acuity was 1.21, which was very highly significant post-operatively, as we can see in the curve. There were few IOP spikes post-operatively which were treated with AGM. 6 of the patient had to undergo vitreous lavage, and all of them were diabetic vitreous hemorrhage for PDR. So to discuss, the incidence of vitreous hemorrhage was shown to increase significantly with age due to increasing incidence of the causes of vitreous hemorrhage in these ages. Main presenting feature was dimness of vision. The incidence where vitrectomy was required in the present study is 0.29%, and in the other studies they have found it to be 0.20 to 0.27%. I had found the period prevalence to be 0.005, and majority of the causes of vitreous hemorrhage were for PDR, but in the other study it was for PVD. And the post-operative complication, as in the other study, is IOP spikes, which were, AGM was enough to treat those cases, but in my cases, one of the post-operative complication was revitrectomy, vitreous bleed, recurrent vitreous bleed. Because most of the cases were elderly age group, there was cataract at 19, but because of the better technological advances for vitrectomy along with a better viewing system, we had only one simultaneous phacoemulsification surgery done. So to conclude, the period prevalence of non-resolving vitreous hemorrhage is 0.005. Variable etiologies at any age, gender, and with various systemic associations. There may be wonder at the time of vitrectomy. Microincision vitrectomy at the earliest possible can be done to treat and find out the exact cause if done on time, and the outcome is very favorable. There may be complete visual recovery post-operatively in some of the cases, and there is no major complication. And revitrectomy may be required sometimes, of course. You can also see in the second case, representative case, 50 years, hand movement at presentation, and 1 month post-vitrectomy.
Your time is over.
Last slide, sir. It's 2020. These are my references. Thank you for your patient hearing.
So, over to the panel. Any queries from the panel? So, any queries from the house? So, I want to ask one question. If in the vitreous hemorrhage cases, which is not caused because of this PDR, any role, just I am asking, of anti-VEGF?
That's what I try to find. We had not given any case of anti-VEGF, so I would preferably not go for anti-VEGF until and unless the anti-VEGF is extremely required. I will go for vitrectomy, do a good laser, and then follow up the patient, maybe an angiography later on if required, and if the angiography shows leakage, then only I would think about going for anti-VEGF, because again, like extra expenditure for the patient.
Thank you.
Acha Gitubani,
yes, ma'am.
Your presentation is very nice presentation.
Thank you, ma'am.
You See, normally we wait in case of vitreous hemorrhage for at least 3 months.
Yes.
If there is no other emergencies like retinal detachment and all.
Yes.
So at what time you have, what is your time interval when you have done this thing?
Yes, conventionally 3 months time is written in all texts. We are also been taught to wait for 3 months before intervention. But I have seen that like one case I have shown here, if we are BRVO and we wait for 3 months till the retinal detachment develops, then even if you do vitrectomy, you might not be able to give the patient a reasonable amount of vision once the TRD sets in. So I prefer to do it as early as possible, because doing a vitrectomy in a advanced setup like what I am having now is not it's not a very, like, I don't prefer to wait for 3 months, because I don't want to treat the patient with complication. I would rather treat the patient without a fresh vitreous hemorrhage without having any complication in the retina.
So whenever, I just like to say that whenever you see there is a traction, you just go for vitrectomy, no?
No, traction I will find only after clearing the vitreous. That is on the table I will see that the patient is having traction, or in the BA scan probably. I don't wait till the traction develops. I go like before, and depending on the visual acuity. If it is hand movement, I will go the next day only surgery.
Okay, thank you.
Just want to ask one question. If dense vitreous hemorrhage, can you give good information from B-scan regarding any traction, any detachment?
Yes, B-scan is only B-scan is the investigation with which we can find out what is inside under the vitreous hemorrhage. But then I have seen that most of the cases, even B-scan, we are still in doubt. Like, this can be, this cannot be.
If the vitreous hemorrhage is very dense, then also you can get information?
Yes, yes,
okay.
We can.
Okay, thank you. Sure.
Okay, sir.
It is required, okay. I don't need this one, generally speaking. So, regarding the incidence of vitrectomy, required vitrectomy, you have shown only 0.27. I really wonder, because except probably in Eels disease in a very young, we used to teach that 3 months to 6 months you wait, everything will be cleared and patient will regain 6/6 vision. That used to happen long back in Eels disease. But with diabetes, diabetic retinopathy with vitreous hemorrhage, madam, incidence only 0.27%. I really wonder. I am getting difficult to agree with you, because vitrectomy, I think almost all of them should require vitrectomy with vitreous hemorrhage and with setup like yours. Why on earth you wait for complications to happen? Thank you.
Yes, sir. Sir, I would like to clear your doubts, sir. I had a total vitreous hemorrhage of 260 during the time of my study, and out of that I had done vitrectomy in 1/4 of the patient. So that's why it is coming to be 0.27%. But if I increase my period, then it will definitely increase.
So, thank you, Dr. Gitimoni. So, going to the next paper. This is interesting paper, hazardous effect of holy colors on eyes, an observational study in a tertiary eye care center by Dr. Preeti Rekha Das.
Good morning to everyone present here. My name is Dr. Preeti Rekha Das. I am here to present my topic, hazardous effects of holy colors on eyes, an observational study in a tertiary eye center in Assam. Coming to the introduction, holy celebration usually involves throwing of colors on one another or directly applying on one another's face. Holy colors usually come in different forms, including paste, powders, or usually filled with watercolors filled in syringes like pitchcaries or balloons. These colors often contain toxic compounds and can enter directly or indirectly into the eye and damage the ocular surface, which can lead to varying ocular manifestations. Coming to the aim is to describe the pattern of ocular manifestation in patients presenting to the outpatient and the emergency department with ocular complaints following the exposure to holy colors. It was a hospital-based observational study. 13 consecutive patients presenting to the outpatient and emergency department with ocular complaints following the exposure to holy colors were taken. All the patients who had ocular complaints prior to exposure to holy colors were excluded. A thorough history regarding the chief complaint, duration of symptoms, and how the injury occurred were taken. A complete ocular examination was done, including slit lamp examination, fluorescent staining to look for any epithelial defect, recording of the visual acuity, and fundus examination. Coming to the results, majority of the patients were males and were young adults between 16 to 35 years. Most of them resided in the urban area. Most of the patients presented on the same day or the next day. One of the patients presented after 2 days. Most common mode of injury was direct application of the colors which entered directly into the eye. A balloon injury was noted in 3 of the patients. Most common presenting symptom was foreign body sensation or irritation and redness, followed by watering and swollen eyelids, pain, and decreased vision. Visual acuity in most of the patients was between 6/6 to 6/9. Two of the patients had vision between 6/24 to 6/36. On examination, the following findings were noted. In the eyelids, swelling was seen in 3 patients, eczema of the eyelid skin in 2 patients, conjunctiva condition was seen in almost all the patients, chemosis in 2 patients, subconjunctival hemorrhage in 1. In the cornea, punctate erosions were seen in 1 patient, abrasion in 2 patients, and ulcer in 1. In the anterior chamber, cells and flare was seen in 2 of the patients, and hypema following balloon injury in 1 patient. Here are some of the pictures of the patients. Coming to the discussion, in a study, Dada et al. Reported around 40 patients presenting to the casualty after sustaining injuries due to colors during Holi festival. Majority of them were males, and 95% of those patients had chemical conjunctivitis. Followed by the other most common findings were superficial punctate keratopathy and corneal abrasion. Gupta et al. Also reported 13 consecutive patients attending to the casualty department after Holi festival with ocular complaints. The mean age in their study was 33 plus minus 10.49 years. Most of the patients in their study also had foreign body sensation. Another study, out of 210 patients presenting to the trauma center, 28 patients were due to Holi sustained injury. Pujari et al. Reported 21 patients with ocular manifestations following exposure to Holi. Chauhan et al. Reported a case of bilateral periorbital necrotizing fasciitis, which was a complication following exposure to the Holi colors. Coming to the conclusion, traditionally Holi was played using plant or natural tree extract. But over the years, these colors have been replaced with toxic substances, and which is causing the problems. And these toxic compounds can cause harmful effects not only on the skin, also to the eyes. Therefore, in order to prevent ocular morbidity, this can be prevented by creating awareness among the public and also using natural colors instead of toxic compounds. These are my references. Thank you.
So interesting presentation, Dr. Preeti. So as it is a emergency conditions after Holi, so how you have treated your cases? Because some cases having the uveitis, some cases having the corneal problem, and some cases having the subconjunctival hemorrhage. At emergency, as a doctor in the emergency department, how you have treated your cases and how you have followed your cases?
So depending on the presentation, they were managed. For example, if there is only just corneal if there is only irritation and foreign body sensation and congestion, they were managed topically on antibiotics, and a low dose, if the cornea was not involved, then low dose topical steroid was given, and depending on the symptoms, if there was pain, accordingly analgesic and anti-inflammatory were given. Most patients usually presented with congestion and irritation and foreign body sensation. So they were managed accordingly, and also artificial tear substitutes were given. And then after, if there was corneal involvement, they were actually admitted for close follow-up, because it's a chemical. Chemical injury usually requires steroid. So because there was corneal involvement, in order to monitor, they were admitted, and they were started on antibiotics, topical antibiotics, and low-dose steroid.
Okay, so this is a very simple problem, but it may land up in a very serious problem, yes? So what you have to do when a patient arrives at the emergency after immediately entering this holy powder inside the eye, your first thing, like your chemical bath, you should go for irrigation yes, to wash out all the materials. So there should not be any toxic materials inside the eye. Then accordingly, then you examine and go for the treatment.
Good one, nice presentation. I think from our association, we should have public awareness just before Holi, so that at least we can avoid the chemical ones. Because not only powder, nowadays this liquid one also comes, which enters to the eye and harms the eye. Public awareness programs should be there. Thank you.
So, any questions from the
share
house?
with you and add one thing. In quite 2-3 years back, one young boy came to me after 7-8 days of holy powder injury. Actually, he treated locally, but his symptoms did not disappear. And when I examined, I saw some of the holy powder still in the upper conjunctival sac, and after under anesthesia, when I removed it, I found that it is conjunctiva is already eroded, and it is about to form symbiotic there. So I had to treat accordingly with lubricants and steroids and ointments frequently. For at least for 5 days, I asked her to come daily for sweeping so that symbiotic does not take place. So this may also happen sometimes. So we have to take care of the conjunctival sacs very carefully while examining such patients. Thank you.
Thank you, Dr. Piti. So going to the next presentation, a clinical study on risk factors and pattern of ROP in a tertiary eye care center.
Excuse me, sir, I had a question for the last speaker actually. You mentioned the holy pigment. Did you analyze the pigment, what was used? And number one. And number two, you told that we can use organic products. So suppose even if a plant product enters into the eye and it causes, whether my treatment modality will change, whether I should use steroid or not, if the injury is by some organic product, as you have mentioned in your last slide.
First of all, analysis of the toxic compounds could not be done, and because there was lack of investigation, but also in some holy powder packets, there is no proper mentioning of the composition of the powder, so it is very difficult to find out which product or which compound is exactly causing the irritation. Natural compounds can also cause irritation, so accordingly we have to treat them.
Okay. I think a proper history of what compound was actually used which caused the injury should be taken.
Dr. Sibasis, the patient cannot tell what compound is used. So this is done by some other people, and And whatever it is, whether organic, non-organic, it doesn't matter, but we have to add one antibiotic to prevent infection. Otherwise, usually it produce an allergic problem, but whatever it is, antibiotics should be added to prevent your secondary infection. And that, that compound cannot be identified sometimes also.
Thank you. Next to the next presentation. Dr. Ipsita, please go on.
A very good morning, everyone. I will present a paper on a clinical study on risk factors and pattern of retinopathy of prematurity in a tertiary care center. Retinopathy of prematurity affecting premature babies is one of the leading causes of avoidable childhood blindness worldwide, especially in developed countries. In recent years, establishment of intensive neonatal treatment regimen is causing a rise in incidence of ROP in developing countries among premature babies who would not previously have survived. The aims are to study various risk factors of ROP and to study patterns of ROP. All neonates with gestational age less than 34 weeks, with birth weight less than 2000 grams and born with risk factors like prolonged oxygen requirement, respiratory distress syndrome, sepsis, phototherapy, hyperbilirubinemia, gestational diabetes, hypertensive disorder of pregnancy were included in this study. This hospital-based retrospective observational study was done in RIO GMCH from March 2022 to February 23, while 90 babies were selected for screening as per the inclusion criteria and thoroughly evaluated by proper history taking and examination. The pupils of selected babies were dilated using eye drop tropicamide 0.4% and phenylephrine 2.5% at an interval of 15 minutes till optimal mydriasis and then examined by indirect ophthalmoscope for presence of features of ROP. The collected data were observed through a master chart and results were statistically analyzed. In the study, out of 90 babies screened, 14 babies were diagnosed of having ROP in both eyes, making the incidence 15.55%. This shows the distribution of babies with respect to the birth weight. In this study, the mean birth weight of all babies were found 1468 grams, whereas in ROP babies it was found 1224 grams, and the p-value of birth weight was found to be very significant. This is the distribution of babies with respect to gestational age at birth. The mean gestational age of all babies was found 31.4 weeks, whereas in ROP babies it was 28.5 weeks. The p-value of gestational age was also found to be significant. Out of 54 total babies who got the oxygen supplementation, the 13 babies developed ROP, that is 24.07% of the babies who got the oxygen supplementation developed ROP. So the association between oxygen supplementation and ROP was very significant, and the distribution of babies with respect to respiratory distress syndrome developed in the postnatal period. Out of 39 babies, 10 babies developed ROP. Out of 25 babies who developed neonatal sepsis, 8 babies developed ROP. The p-value was marginally significant, and out of total 32 babies who got phototherapy, 9 babies developed ROP, and the p-value we got in this study was significant. Out of 35 babies who developed hyperbilirubinemia, 9 babies developed ROP, and the p-value was marginally significant. Out of 26 babies who had a mother with gestational diabetes mellitus, 5 babies developed ROP, and the p-value in this study was not so significant. Out of 29 babies who had a mother with hypertensive disorder of pregnancy, 6 babies developed ROP. In this study, we do not find so significant p-value. So out of total 14 babies, that is 28 eyes diagnosed with ROP, the 8 cases, that is 16 eyes were found in stage 1, of which 5 cases were in zone 3 and 2 cases were in zone 2. 3 cases, that is 6 eyes were found in stage 2, 2 cases, that is 4 eyes were found in stage 3, and in 1 case, 1 eye in the stage 4 and the other eye in the stage 5 was found. In our study, the incidence of ROP was found 15.55%, similar to Diveti et al. In the Madhya Pradesh. Gestational age and low birth weight babies were found to be the strongest risk factor for development of ROP, similar to the cryo-ROP study by Schaffer et al. Other risk factors with significant association of ROP in this study are oxygen supplementation, RDS, phototherapy, similar to studies with Campbell and Ashton and Park et al. Out of total 14 diagnosed ROP babies, 8 cases were found in stage 1, 3 in stage 2, 2 in stage 3, 1 case, 1 eye in the stage 4 and other in stage 5 was found. So the incidence of ROP, mean birth weight, gestational age at birth in this study are comparable to other studies. The risk factors with significant association with ROP are prematurity, low birth weight, supplemental oxygen, RDS, phototherapy, hyperbilirubinemia. Gestational diabetes, hypertensive disorder of pregnancy and neonatal sepsis did not show significant association with ROP in this study. The pattern of ROP among 14 cases were 8, 3, 2, 1 in 1, 2, 3 and 4 to 5 respectively. Judicial use of oxygen, protocol-wise screening and follow-up of babies with risk factors should be done without delay for prevention, early diagnosis, management of ROP, thus decreasing the overall burden of blindness in future at least to some extent. There is no conflict of interest and no financial support. These are my references. Thank you.
So, any queries from the dais?
It's not exactly query. But even nowadays, all the district hospitals, they have neonatal ICUs and all. But I don't think all district hospital has the facility of diagnosing this ROP. So most of the, I think, cases are undiagnosed. Only in Assam, I think hardly few centers are having these facilities of examining for ROP and all. Anyway, your presentation was nice. Thank you.
Thank you, sir. Thank you, sir.
So we are having the very, time is very short. So thank you, Dr. Ipsita. So coming to the next interesting paper, challenges faced by young ophthalmologists in primary healthcare center, set up by Dr. Soubik Borua.
Thank you, sir. A very good morning to all. At the outset, I'd like to thank the scientific committee for allowing me to present this topic. So since I've been working in a primary healthcare setup since last 1 year, so I'll be sharing some of my experiences. I'll discuss about the solutions also, or the improvising techniques that I've come up with to overcome these challenges. So to introduce my topic, we all know eye care. Thank you. To introduce my topic, we all know eye care is an integral part of primary health care. It's because there is a strong relation between visual acuity and quality of life. Also, there are some other aspects like detection of reversible blindness, managing trauma cases, emergency cases like acute angle closure glaucoma before referral, etc. So, but in periphery or in the primary healthcare setups with very limited resources, providing quality eye care is very challenging. And every day we have to come up with innovative techniques and improvising to give proper eye care. So this also helps in reducing the burden in tertiary eye care centers. These are some of the challenges that I have been facing since last 1 year. The main being the lack of resources. Also, there is very limited training opportunities for doctors. There is also lack of patient awareness and education, and also there are workload and time constraints, apart from absence of proper referral services. The main problem or the challenge is that there is a lack of resource. In some centers, like my center, there is even lack of basic equipments like slit lamps and auto reflectometers, leading to missing many important diagnostic signs, and this leads to less patient satisfaction and thereby leading to less job satisfaction amongst doctors. So the only solution that I have seen is that we as doctors have to purchase less expensive and portable instruments whenever possible to provide good quality eye care. We all know that the slit lamp is one of the most important diagnostic tool that we use regularly, but when the slit lamp is not available, we can use other means like a binocular loop that we have been using. Also, in some cases, if you want to have slit beam images, we can use a direct ophthalmoscope along with a 20 diopter bulk lens. And using the slit filter in the direct ophthalmoscope, we can get slit beam images. For example, if you want to see assess the entry chamber depth. Then if the auto-refractometer is not available, like in my center, so what we do, we go with the time-tested method of retinoscopy. Using a strict retinoscope, this allows us to do proper refraction and give spectacle correction. Then to see the posterior segment in our setup, or in most of the setups, indirect ophthalmoscopy or slit lamp and 90D is not available. So what we do, we carry our own direct ophthalmoscope and we see the posterior segment. Sometimes I also use a mobile camera along with a 20 diopter lens to see a panoramic view of the posterior segment. Like I have shown, we also use some basic instruments we carry with us for minor surgical procedures, like these lenses that I have shown, and a few forceps. Also, another challenge that I have faced is that lack of training opportunities. Actually, CMEs and workshops which are mostly considered in urban areas, doctors in primary healthcare setups cannot attend these CMEs. So, but nowadays, with the advent of proper technology, webinars are being introduced, and this problem it's easy to overcome this problem. Also, in medical colleges and tertiary care centers, novice ophthalmologists like me get to work under experienced ophthalmologists. But in primary healthcare setups, I am the only ophthalmologist. So I feel I lack the work exposure under experienced ophthalmologists. So I feel the government should come up with rotation programs in urban centers and medical colleges so that doctors like me can get proper exposure. Due to these reasons, we have seen that many doctors working in periphery, they want to quit their jobs, and as a result, there is scarcity of doctors, specialist doctors in the primary healthcare centers. To mitigate this problem, the government should come up with policies like providing incentives, subsidies, and other scholarships to retain the doctors. Then another important challenge is that patients mostly come from poor educational background in primary healthcare centers, and because of this, it's difficult to convince the patients about treatment modalities and the need of proper lifestyle, good nutrition. So to overcome this issue, I think we can always involve the grassroots level workers like ASHAs and ANMs, or we can engage the local NGOs to organize camps, then we can go for support groups, we can distribute pamphlets, etc. There is also one big issue. No matter what specialty a doctor is working in a periphery, in a primary healthcare setup, he has to do some other work like providing obstetric care, emergencies, then conducting autopsies as well. And also the number of eye patients in OPDs are quite a lot. So it's difficult to go for a thorough ophthalmic examination leading to missing diagnostic signs. So I think to overcome this issue, we should always, while examining a patient, we should always follow a standardized checklist. This will help us in providing in a proper way, examining in a proper way, and we should also engage support staff like ophthalmic assistants and nurses. Then the last problem, that is the absence of proper referral services, because sometimes the referral centers are quite far away there, and there might be transportation and logistics issues. But nowadays, with the setup of newer medical colleges in almost every district, I think this problem will be able to overcome in next few years. So this is my last slide. The only good thing that I have seen in a primary healthcare center is that the specialists of different branches like eye, ENT, dermatology, etc. work under the same roof. So if we need another opinion with the patient, we can have that opinion very fast. So the patient need not move around looking for specialists in other departments. So the take-home message of this presentation is that despite the challenges, with the application of innovative techniques and ideas along with social support, we can always provide improved eye care services in a primary healthcare setup. Thank you.
So it's a nice presentation by Dr. Soubik, and that is why we always ask in the medical college to our students so that clinical judgment should be better. So every time we cannot, we have so much of diagnostic tools, but we cannot get in the peripheral hospitals and primary healthcare centers. So clinical judgment should be, if don't have the corneal topography, then we have to window reflection, Placido's discs, and the retinoscopy, loop, even loop also, because cannot get the slit lamp also. So these are the important. Now government has introduced the DRC program for 3 months program in the peripheral hospitals, peripheral medical colleges which are far away from the cities. So that students can at least know how the along with the clinical judgments, how a patient can be treated or patient can be referred to the proper places. So anything.
So Vic, thank you because you have highlighted the practical problem. Yes, I feel for the young ophthalmologists, once they passed out, they are posted in such, sometimes in such areas where there is no at all eye facilities, yes, to treat eye problem. Because they have to do some other duties also. Not like the eye patient, they have to do medicine duty, emergency duty all time. I have seen many of our students and they are posted in such places, they forget after 6 months what they have learned their PGT time, they forget everything. So we should, I think, from the Ophthalmic Society, I want to make a request for one, that they can make a proposal to the government, they can place a proposal to the government regarding the placement of especially ophthalmologists, because each and everyone cannot carry their own instruments and equipments. So we should think about them regarding the placement. What other people think can express?
Thanks, Sovik. Yeah, yesterday we had a debate where the youngsters to go. They have shown only medical college and private practice. But our health and family welfare, there is also a lot of scopes are there. And that's how he has faced the problem. Assam government under health and family welfare, they don't appoint as specialist. Ophthalmologist, master degree, he will be appointed as medical and health officer 1. Next promotion will be senior medical officer, then SDMO, then CMO, then joint director. These are the posts in under health and family welfare. Now, even from other departments also, hardly anyone is joining. Around more than 2,000 posts are still lying vacant. So the peripheral centers, even the district hospitals are running of shortage of manpower, especially the doctors. That's why in a primary health center, you cannot expect the specialist services. There are hardly 1 or 2 doctors. Usually the posts are 3 or 4 sanctioned posts are there, but most of the primary health centers are running with 1 doctor only. And he has to do all the treatment side, all the diseases, medical legal cases, that to report to the police and to attend the courts also to give the witnesses. And above and all nowadays the national programs are coming out. Right from immunization, rabies, malaria, what not. Every disease the government is going to control and eradicate all the diseases. These are being put into the primary health centers only. So now all after passing the postgraduate, 1 year compulsory is given posting in the rural centers. So they had to do all these programs. But once you join and do it, you will enjoy. I just completed more than 36 years of service in health sector and just retired last 31st of March. Yes, I really enjoyed. You will enjoy. I request young ones, please join the health and family welfare sector also. You will enjoy the services. That's all. Thank you.
Thank you, Dr. Sovik.
So a very nice presentation. You are coming with a very legitimate question that why infrastructure is not developed in the primary healthcare centers. Actually, in our state also, our health department has improved the infrastructure in many specialties, but ophthalmology is most of the times overlooked. Actually, the cost of a slit lamp, cost of a indirect ophthalmoscope, at least the Indian ones are not very much more. Within 3-4 lakhs it comes. Quite a few of the instruments, which the new young ophthalmologists in the primary healthcare center can be of much help. So from our forum, from our society also, we raise this question, raise this information to the government that at least this much of investment, this much of infrastructure development should be there in the primary health care centers. That should be a message from our side. Thank you.
Thank you. Autoclave, it's not a remote area, it's a sub-regional civil hospital. We don't have a separate OT for eye care services, but in the minor OT, not surgery per se, but we can always do a kaziranga surgery like that, and we sterilize with the regular autoclave machine, because OT is there, but eye care separate OT is not there in my place.
Just one point. Recently, government of Assam has appointed many optometrists. From our Ridley College of Optometry, 24 optometrists have been appointed by the government of Assam. They are very good in refraction, sleep, everything. They are very good for workup. Now, if at least one ophthalmologist is put in the civil hospitals and in the primary health centers, I think the eye care will be much improved. So this is I think we should, Ophthalmical Society of Assam should speak with the government so that these optometrists are properly placed, and that will definitely enhance the eye care of our state.
And this was there earlier. Yeah, recently the government has appointed. Earlier, it was the post of ophthalmic assistant. The course was there in the medical colleges for 2 years. And those were only appointed as ophthalmic assistant in the PHCs. And that course was closed. And those who were there, most of them retired, and hardly few were there. So this time, seeing this, the government has appointed the optometrists also in that ophthalmic assistant. So I think in the periphery, if they do, and in the district hospital, almost all the district hospitals, they have the cataract surgery, and all the districts are well equipped with the microscope and all. So bulk cataract surgeries are going on, and I think you can, once you are working in the district hospital, so you will be getting a lot of cases to operate. Thank you.
So I would really like to congratulate you, because you're working in a center with the limited resources and you're delivering excellent. You're trying to deliver your knowledge to those people who cannot afford. Thank you, and congratulations once again.
Thank you so much, ma'am.
I served the Assam government as an advisor to the government of Assam, ophthalmic advisor, and the director of health service. I remember that I have given instruments and appliances to all the district hospitals and community health centers from Delhi. I brought everything. I don't know why it has not been practiced there. At that period of time, I once visited Bopata Hospital, where I found that the ophthalmic instruments are kept aside, and then I am to take the inspectors from Delhi, what you have done with these instruments. I have shown some other instrument as the ophthalmic instrument, and somehow or other satisfied and sent him back by air to Delhi back. That was the problem there. Second problem was the ophthalmic assistant was appointed first, and then they are taught. They don't care whether they learn or not. So in Delhi meeting, I raised this point that day will come that when there will be a disease called ophthalmic assistant disease. They don't have any knowledge. They are already appointed. They know they will get the job. So they don't like to, fortunately that everybody has retired. Otherwise it would have been a problem. Now I wanted to know from Narayan that you are teaching these people, are you taking examination of them? or properly taught. Otherwise, they will create a distance, because I was once held out by all the ophthalmic assistants in my department for 12 hours, because they are supposed to visit 5 kilometer area and detect the minor ailments, refer it to the community health center. They become a doctor. They want a chair, they want a room, they want the signboards and everything. So, and they want a scooter. Are alidi jabo lagibo, cycle is better. Tumi scooter ko chalaba gaot. Hey karone mo gherao kori pelale. Gherao kori kole je scooter sanction koroni. What are you doing? Tomar kaam hol alidi joa, ঘরে ঘরে গৈ পেলাই চোৱা, আৰু তুমি নিজে ডক্টৰ হৈ গ'লা। এইবোৰ লৈ বহুত প্ৰব্লেম হৈছিল এক সময়। আল্টিমেটলি যেটো বন্ধ হৈছে, অপথেলমিক এচিষ্টেণ্ট ভাল হৈছে, কিয় আগতে এপইণ্টমেণ্ট, তাৰপিছত পৰীক্ষা একোৱেই নাই। দ্যাট ৱাজ দি প্ৰব্লেম দেয়াৰ।
Definitely not up to the mark, more than the mark actually. And they can very jolly well walk. And 64 a ophthalmic assistant has been appointed, and I think everyone has got. In my college, some medical college also, I got 2, one optometrist and one visual rehabilitation assistant. So I think everyone will get this. Optometrist. No, optometrist I am telling. I am telling optometrist. Yeah, they are very good, very good. No. Thank you.
So thank you, Dr. Sobi. So directly we will going to the next presentation. A clinical study on pattern of
Excuse me. Let me give some supplementation. I think the topic offered by Dr. Sovik is a very important one, and I think that it needs some supplementation. I was holding the post of additional director of health services for a pretty long time. Before that, I was district surgeon at Golaghat Civil Hospital. I could see that there are some instruments were sent to district hospital. I was in district hospital, I got some keratoplasty instrument, 2 sets, at the cost of good SICS instruments. Again, as an additional director, when I visited some hospitals, once I visited Titavur Subdivision Hospital. Anyone from Titavur? I could see 2 auto-reps there. I then wrote to the Rohat district joint director of hospital to rationalize this instrument to some other place where it can be utilized. Another very big hospital I went, district, I will not name it, the auto-rep was gathering dust. And I asked the ophthalmologist what he was doing actually, why he is not utilizing that. And another most important point is that I also feel pity that these days it may be irrelevant that some retinal operation not done in medical colleges. I don't know why. We have to send refer patients to private hospital where cost is prohibitive. In that case, patient advise us, shall we go to Nepal? Yes, you can go there. And what is the cost for a patient? It is 35,000. They get it done by 10 or 15,000. I've seen that they are doing very good, successful operation also. So my request to Dr. Jyoti, who is holding the post of director now, and with that position, she is also ex-officio direct advisor of the government of Assam, ophthalmic advisor. She should write to the government for rationalizing these things. And more new young doctors, ophthalmic surgeons should be inducted for retinal operation. I know all are only going for what is called phaco surgery eye. Maybe perhaps they may be earning more. That may be the factors. But then at the cost of we are good retinal surgeon. That is the very most important point.
Can I make a point in this?
Please.
Now I'm in
Definitely.
Guwahati, and the point that you are not having retinal surgery in our institute
Right.
is something very pitiful.
Yeah.
I don't know why it is not happening. We have an expert in retinal surgery also. but it is not working. I'm trying my level best to get it work. So let's hope in your future you will not have this complaint in this forum.
Yeah, that is the crying need of the day.
I understand that. I understand it. It's very much essential.
Very
I'm
much.
also feeling very embarrassed to tell you all that it hasn't been worked out.
Yeah.
So everything is not working as it should have been in the retina section. We are having medical retina,
Yeah.
but the surgical retina in RIO is not working. So I'm trying my level best, and with your blessing and your best wishes, I hope it can be done shortly.
Okay, thank you.
Thank you, Wanda and Subra, for your inputs. We are running short. Please, next.
Okay, please continue, Ipsita. Present your case.
Good morning everyone. Now I will present my paper on a clinical study on patterns of vernal keratoconjunctivitis among children attending outpatient department of a tertiary care center. Vernal keratoconjunctivitis is a bilateral recurrent immune-mediated inflammation of conjunctiva occurring especially with the onset of the hot weather. The aims are to study demographic profile of VKC and to study pattern of clinical presentations of VKC. All children with age 0 to 18 years with a clinical diagnosis of having VKC were included in this study. There are no conflict of interest and no financial support. This hospital-based descriptive cross-sectional study was done in outpatient department of RIO GMCA.
What are the doubts in vitreous hemorrhage is, despite recent improvements in ophthalmologic diagnosis